అదే కదా అయితే అంతే ఓకే స్టార్ట్ ఇది మ్యూటా చాలా మన ఇద్దరు మాటలు వినబడుతున్నాయి అందరూ మ్యూట్ చేసుకుని ఉన్నారు మన ఇద్దరు ఓకే నువ్వు అన్మ్యూట్ చేసి ఉంటావు మేబీ నా డివైస్ నుంచి ఇద్దరు మాటలు వినబడి ఉంటాయి
ప్లీజ్
It is also endopathic severe hematology is for the syndrome that potentially attack the organs and
Hello.
అది ఫుల్ వర్షన్ పీపీటీ ఫుల్ వర్షన్ కాదా ఓపిక పోతా వల్ల ఓపిక ఎవరైనా నడుస్తారేమో చాలా మెసేజ్ చేస్తా కేసెస్ ఎవరైనా చూస్తారా అని
Good morning, Sharma. I am available. Good morning, Sharma.
Related duty. ఎట్లా అయిందంటే ఫుడ్ సప్లైర్ ఉన్నారు కదా ఆయన బ్యాటర్ ఏమో
అదే మీది వచ్చినప్పుడు మీరు చెప్తారు కానీ సార్ జస్ట్ ఇంకా బిగిన్ చేయలేదు డ్యూ టు సమ్ టెక్నికల్
అలాగే సార్, అలాగే సార్.
ఎలాంటి పర్సన్స్ ఉన్నా
నేను జస్ట్ నాకు పిలవండి, నేను జాయిన్ అవుతాను. జస్ట్ 1 minute. ఓకే.
మనం ఇక్కడ కనపడమా? మనం కనపడమా? ఇప్పుడు మనం కనపడతామా లేదు స్క్రీన్ మీద?
కనిపిస్తారు.
ఇప్పుడు ఇక్కడ ఎలాగా ఏం చేయాలి?
అవును, ఇంకా ఉన్నాయండి. అందరూ లాగిన్ అయ్యాక
ఓ, అచ్చా, అచ్చా, అచ్చా. సరే. ఆ?
వీడియో వస్తుంది సార్.
ఆ.
staging the patients వచ్చిన వాళ్ళని staging చూసుకుంటారు సార్.
Staging 1, 2, 3. సార్ ఒక 5 minutes దాకా నేను అడిగా అంటే ఏం లేదు, ఏపీఐ ఫిజిషియన్ అసోసియేషన్ ఆఫ్ ఇండియా వాళ్ళది స్టేట్ కాన్ఫరెన్స్ ఆన్లైన్ అవుతుంది. నేను దానికి ఏపీఎంసీ అబ్జర్వర్ జస్ట్ మీటింగ్ చెప్పేసి నేను
ఓకే సార్, అంటే పేషెంట్స్ వస్తే చూడాలి ఏం మాట్లాడాలి సార్. బాగుందండి ఇది. కెన్ ఐ హ్యావ్ ఎ కాపీ ఆఫ్ ఇట్? బాగుంది, నాది వేరే
వచ్చేసింది. హలో
Please start the inauguration, sir.
హలో
Please start the inauguration.
స్టార్ట్ చేసాను.
చేసాను సార్, మీకు వాళ్ళు మాట్లాడే వినిపిస్తుంది సార్.
Respected members of AP chapter of API, dear delegates, honorary guest faculty, and dear postgraduates, good morning and welcome to all of you to this much awaited AP State Physicians Conference, EAP APICON, being organized by the Department of Medicine, Konaseema Institute of Medical Sciences, and API Amalapuram, on a virtual platform for the first time in the history of AP API, in view of the existing COVID situation. So let us start the scientific schedule of this conference with our AP API's customary protocol of brief inaugural function of the scientific session. Please stand by for the special announcement to all postgraduates after this brief inaugural function. Please play the video inaugural function. చెప్పండి. ఏది చెప్పండి.
Faculty and other dignitaries to this much awaited scientific feast, AP APICON 2021, the 48th Annual State Conference of Andhra Pradesh Chapter of API. It's my pleasant duty to invite the following dignitaries for formal inauguration of the scientific session. Dr. M.B.R. Sharma, Chairman of Organizing Committee. Vice Chairman, Organizing Committee, faculty and other dignitaries to this much awaited scientific feast, AP APICON 2021, Honorary Secretary of AP State Conference of Andhra Pradesh Chapter of API. It's my pleasant duty to invite the following dignitaries for formal inauguration of Organizing Committee. Vice Chairman, Organizing Committee, faculty and other dignitaries to this much awaited scientific feast, AP APICON 2021, Honorary Secretary
And also become enriched by the knowledge that has been communicated by the reference. For Paramount is also very very happy. It is also a very happy event, and the Association of Physicians of India has decided to award cash prizes for all the efforts that and they are sponsored also process of medicine and senior physician doctors in our industry. We have been doing it for several years. Also planning very happy. It is also a very happy event, and the Association of Physicians of India has decided to award cash prizes for all the efforts and they are sponsored by process of medicine and senior physician doctors in our industry. We have been doing it for several years. Also planning decided to award national prize for all and they are sponsored by Professor Secretary and Senior Affiliation Doctors in Inauguration Industries. So we are
Thank you, and sorry for the delay in initiating this program due to some technical snacks. Anyway, dear postgraduates, altogether we have received and approved more than 500 platform and poster presentations. So more than 250 in each category of platform and posters. So we have 7 groups of judges who have gone through your pre-recorded virtual presentations patiently. Now please log on to your corresponding platform presentations first and poster presentations later. And just a word, some of you have exceeded the very much the time limit of 6 minutes presentation for platform and 3 minutes for poster. And somehow created a very overcrowded slides projected. This may in fact uh, call for disqualification in a national or a very strictly conducted scientific fora. However, we have considered all these for presentation. Please remember this in future and correct yourself, those of you. Please, one more caution is for all the delegates. Please remember to log in for the entire scientific schedule type to get your certificates as per AP Medical Council regulations. Let us enjoy the academic fun today and the academic feast in the next 2 days. Now I request Dr. P.S.N. Sharma, our Honorable AP Medical Council Observer, to give his brief message. Dr. P.S.N. Sharma.
Good morning, all of you. It's my pleasure and privilege to be here with all of you and interact with you virtually for this wonderful conference. So at the outset, let me thank you for the opportunity given to me, and I bring greetings from the AP Medical Council for a wonderful and interactive session. I also congratulate our respected Professor Ramagaru and also my good friend Jawahar for the initiation they have taken, for all the trouble they have taken. I wish the conference a grand success. Thank you. All the best.
Thank you, sir, for your brief message. And thank you, one and all. And now let us adjourn for the platform presentations category wise. Please, all the postgraduates, you have received the link for the category wise presentation of your platform presentations first, and that will be followed by poster presentation. Thank you all.
Someone from video conference, please on your screen, like on your video. Hello. You can on your video from video. Hello. Yes, sir.
Hello. Hello, Swami sir. Swami sir. Hello, Swami sir. Security. Hello.
Hello. Yes. Judging will be started in next 5 minutes.
I'm taking this paper.
Okay, sir. Okay.
026. Abstract number 026. Ambaraj Haripriya.
Hello.
Abstract number 06 Ambaraj Haripriya. Hello. Ambaraj Haripriya. Next.
He is not there.
Abstract number 079. Anurag Vemula. Anurag Vemula. 079.
Hello. Hello. Sir, this is a neurology and platform.
రాజేష్ ఇయర్ ఫోన్స్ ఉన్నాయా? రాజా మీ వాయిస్.
Hello. Class 1 platform presentation and category it is neurology.
వీడియో కూడా పెట్టండి, వాళ్ళని కనపడేట్టు పెట్టండి క్యాండిడేట్స్. హలో డాక్టర్ గాయత్రి.
Please unmute yourself.
Hello.
Hello Gayatri, Dr. Gayatri, please unmute.
Yes, sir. Yes, sir. Yes, sir.
Okay. So what is your study?
Sir, my study is on serum homocysteine levels in patients of CSVT, sir.
Raja Dinesh, Godapati Raja Dinesh.
Okay. So anyway, I have gone through your presentation.
Yes,
No postpartum women were included. Is it right?
Yes, sir. No postpartum women were included, sir.
So did you correlate homocysteine levels with other comorbidities in a multivariate analysis?
Sir? Hello?
Did you correlate homocysteine levels with other comorbidities?
I correlated with hypertension and diabetes, sir.
Only those two. Okay.
Yes, sir.
Then what is the most common presentation that suggested CVT?
Sir, with mostly they present with superior sagittal sinus thrombosis, sir.
Most common. So what is
Most
the presentation by which made you suspect that superior sagittal sinus thrombosis?
Sir, most common presentation with headache and seizures, most of them are presenting, sir. So, and they were diagnosed by using MR venogram, sir.
Okay. MR venogram is okay. Clinically, what I am asking is, when do you suspect CVT? Suppose if anything, headache or a focal neurological deficit, we always first think of arterial thrombus. But when do you suspect venous thrombus? Venous sinus thrombosis. That is what you said already.
Yes, sir.
Headache, seizures,
headache, seizures,
severe headache, persisting severe headache and seizures, they point often to the CVT. And of course, neuroimaging will be confirmatory. Okay. Thank you.
Okay, sir. Thank you.
Serial number 2, abstract number 007.
Present.
Ram Manindra Chaudhary.
Yes.
Please unmute and please unmute your video also. Please on.
Okay. Hello.
Okay. Next.
Sir.
What is your name?
My name is Ram Manindra, sir.
What is your name?
My name is Chinta Ram Manindra, sir. Hello.
Chinta Ram Manindra. What is your study?
Serum
what is your study?
Serum albumin is a predictor of.
What is your study?
Serum albumin is a predictor of severity of stroke, sir. Cuties. Hello.
Stroke prognosis.
Yes, sir. Predict the severity of stroke and versus serum albumin, sir.
So anyway, what is the how many patients did you study?
100, sir.
100.
Yes, sir.
How many patients?
100, sir. 100.
100. Okay. So exactly what is the mechanism of serum albumin level? What is the relation of serum albumin with stroke?
Actually, serum albumin is a neuroprotective feature is there for serum albumin, sir. Hello.
Yes, Ram, you are audible.
Hello, if somebody's serum albumin is high, don't they get strokes?
No, sir, it's not like
Are
that.
they not susceptible to stroke?
They are susceptible to it's a multi-factor.
Just you made a study, observational study.
Yes, sir.
You made an observational study of serum albumin level and severity of stroke. Okay. What is your final inference?
There is a positive correlation between the low serum albumin level and the severity at the end of 90 days, sir.
So it could be due to other causes also.
Yes, sir. But
so what are the other associations along with serum albumin in a stroke?
Yes, hypertension,
What other
dyslipidemia,
comorbidities?
hypertension.
Hypertension, diabetes mellitus. The morbidity may be related to that only, not directly. But anyway, in your analysis, you said the serum albumin level, how much low is associated with poor prognosis?
Less than 3, it is associated with severe
3 grams per.
Yes, 3 grams per deciliter.
Is poor recovery is associated with.
Yes, sir.
Okay.
Would recover even after 3 months. That is 90 days.
At the end of 3 months, recovery at the end of 3 months.
At the end of
What I am trying to ask you is, trying to find out from you is there a direct correlation between serum albumin and stroke? Because majority of not have heard about it. That's why. Because you have made a new study, definitely a new parameter.
direct correlation, yes, it was existed, sir. Like in this study, what we have, what we have observed, sir.
So you have taken some references.
Yes, sir.
Some other studies.
Yes, sir. There are some studies also.
Okay.
Sir.
Anyway, thank you. Okay. Thank you. Thank you. Thank you. Next. Okay. Thank you. Next.
Abstract number 021,
Hema.
Yes, yes, sir. I'm here, sir.
Please unmute yourself, Hema Pratyusha.
Yeah,
What is your study?
My study is a clinical study of the clinical presentation of intracerebral hemorrhage, sir.
So most common cause, what is the most common cause you made out?
Chronic hypertension, sir.
Chronic hypertension. Okay. So what are the sites where chronic hypertension produces hemorrhage commonly?
Putamen and thalamus, sir.
Putamen, thalamus. Anywhere else?
Cerebellar hemisphere, sir.
Cerebellar, very good, very good. And sometimes brainstem also.
Yes, sir.
So these are the 4 common sites where hypertensive hemorrhage can occur. So my question is, causes of non-hypertensive hemorrhage, common sites. What are the other common sites of non-hypertensive hemorrhage causes?
Can
you make
arteriovenous malformation, sir.
Malformations, rupture. Okay, good. Next.
Cocaine, amphetamine, sir. Cocaine and amphetamine stimulant drugs can cause hemorrhage, sir.
Of course, can cause, but they are not very common. Much more common. People on some drugs. Which drugs can produce hemorrhage?
Oral contraceptives cause or vitamin K.
Oral contraceptives will cause thrombosis.
Vitamin K antagonist and dabigatran overdose or improper dosing.
What do you call them? Those group of drugs, what do you call them? Anticoagulants.
Anticoagulants, sir. Yes, sir.
So those who are on anticoagulants, long term, they can also develop the cerebral hemorrhage. So where do they get in? Which site is more common for them?
Any site, when they have coagulopathy, any site is common, sir. Can be lobar or cerebellar or even at the internal capsule also.
Of course, any site much more common is lobar.
Yes, sir.
So more is a lobar representation would be due to non-hypertensive causes.
Yes, sir.
So very good. Okay, thank you. What treatment you have given? Treatment.
We have based on the consciousness, sir. If they're stuporous, we sedate them and give osmotic diuretics like mannitol, and we see that the cerebral perfusion pressure is maintained at 50 to 70 mmHg, sir. And if they need neurosurgical intervention in case of cerebellar hemorrhages, neurosurgical intervention is required, sir, because brainstem compressions can be common. Otherwise, we give mannitol and we presumptive
measures to reduce cerebral edema only.
Yes, sir. Yes.
Or raised ICT only to reduce raised ICT.
Yes.
Okay, thank you, Dr. Gai. Thank you.
Next Sai Panishankar. Abstract number ABS 024. Hello. Serial number is 4 and ABS 024.
Please unmute yourself.
Dr. Sai Fani. Hello. Please log
Sir
in.
is
Dr.
not there,
Sai
sir.
Fa-
Sir is not there.
Okay, next we'll go to next.
Sai Madhav Reddy.
Abstract number 0044 and serial number is 5. Sai Madhav Reddy.
Sai Madhav Reddy.
Sir,
Please unmute.
sir. Yes, sir.
Okay, what is your study?
Sir, my study is pattern recognition and clinico-radiological approach of myelopathy, sir.
What do you, so in your said, what is meant by pattern recognition?
Based on clinical features, whether involvement of any anterior cord or posterior cord or pan cord involvement, based on clinical features and radiological investigations like MRI, sir.
Okay,
Compare-
radiological leave it. Okay, just wait. What are the, from which clinical features you say anterior and posterior cord syndrome? What clinical
Sir.
features suggest anterior? What clinical features suggest posterior?
Sir, if patient has bilateral lower limb or forelimb weakness, and simultaneously if patient has paresthesia or any numbness like sensations, then we can tell that it is as anterior cord involvement, sir. In posterior cord involvement, patient will have decreased vibration or proprioception sensation, then we can say it's posterior cord involvement, sir. If all these findings are present,
Clinically, listen to me, clinically patient will not say I have vibration sense deficiency. What symptoms do they present with? That's what. You said anterior motor deficit and paresthesia. So
yes, sir.
because of involvement of which tract paresthesia? Which tract?
Spinothalamic tract, sir.
Which
Spinothalamic tract.
Which spinothalamic tract?
Lateral
Lateral
spinothalamic tract.
spinothalamic tract. Very good. Similarly, for what symptoms will have the posterior column, posterior cord syndrome? You said.
Yes, sir.
Symptoms.
They may have white base gaze or falls in night, sir. Wash basin ataxia, like those symptoms they may have, sir.
So what do you call that? Ataxia, which ataxia?
Sensory ataxia.
Symptoms of sensory ataxia and swaying, and with wash basin attacks. Okay, that's posterior column syndrome. And how do you say? You said cervical myelopathy. What symptoms suggest cervical myelopathy specifically?
Specifically, patient presents with quadriparesis, sir. Quadriparesis and any positive or negative symptoms, sensory symptoms, sir. And patient may also have symptoms of sensory ataxia.
Symptoms of?
Sensory ataxia also, sir.
Okay, initially, cervical myelopathy,
yes,
when do you suspect? How do you suspect? What other root pain? Suppose if it is extramedullary,
yes,
what other symptoms they will have? You said cervical spondylitis is the most common cause, you said in your paper.
Yes, sir.
Is
Yes,
it
sir.
not? So what other symptoms they will have apart from motor symptoms?
They may have Lehermite electric shocks like sensations.
It's okay. What is that called as?
Lehermite signs.
Lehermite signs. Apart from that, cervical spondylosis, the roots are involved. Which roots are involved?
Yes, sir. Dorsal roots, sir.
5, 6, 7 most common.
C5, 6 most. C5, C6, C7.
So what symptoms do they have? That's what I am asking.
Distal limb weakness and
Distal limb weakness, which segment which root involvement will produce distal hand muscle involvement?
C8, C6, C7.
C8, T1. Okay, right.
Yes, sir.
If C5, C6 is involved, which symptoms, which muscles will be involved?
C5, C6, biceps muscle, flexion of
shoulder,
flexion,
deltoid,
yes,
supraspinatus, those shoulder muscles. Okay,
yes,
C5, 6
yes,
upper cervical. Okay, anyway, thank you. Thank you.
Thank you, sir. Thank you, sir.
Next, Arif Sheikh.
Yes, sir. Hello, sir. Good morning, sir.
Aditya, na? Huh?
Yes, sir.
Abstract number
Yes, sir.
APS 046.
Arif Shah. Is it?
Yes, sir.
Arif Sheikh. What is your study?
So my study is about the clinical outcome of stroke in relation to admission day glycemic status, sir.
Okay. So what is your findings?
So, finding that the patients GRBS of more than 180, many patients have come with a stroke, sir, with either blurring of vision or weakness of limbs or sudden onset or numbness in the face, arms or legs, sir. Even with aphasia, sir.
No, somebody has presented with a neurological deficit to you. You said at the time of admission, anyway, you measure GRBS. So, in what way that has ultimately resulted in when ultimate findings? What are your observations?
So, a patient with
Those where the
GRBS
blood sugar is high, recovery is poor or more severe. What happened?
So, the mortality is high, sir, and the recovery is very poor, sir.
So, in what way the how do you differentiate whether somebody has got a high blood pressure at the time of admission? It could be due to stress hyperglycemia or already pre-existing patient is not aware but pre-existing diabetes mellitus. How do you differentiate whether it is stress hyperglycemia or already existing diabetes mellitus?
We can send for serum cortisol levels and insulin-like growth factor 1, sir.
So more simple test which you do routinely in diabetics apart from blood sugar.
Urine ketone bodies, HbA1c,
3 months,
sir.
3 months average.
HbA1c, sir.
HbA1c will
hemoglobin,
detect.
sir.
So if HbA1c is high, it indicates for more than 3 months he must be having diabetes mellitus.
Diabetes, yes.
If HbA1c is normal and today's blood sugar is high, it means probably patient has developed stress hyperglycemia. So sometimes hyperglycemia can occur due to cerebrovascular accident. Not only diabetics develop CVA, CVA can also result in hyperglycemia. So that is the way to differentiate HbA1c. Okay, what is the mechanism by which the hyperglycemia is got a deleterious effect on stroke?
So it will formation of lactic acidosis, sir. Then free radical formation, sir. And this the glycosylated compounds will directly damage the endothelial cells, sir. So it initiates the coagulation cascade mechanism, and so increased chance of thrombosis, sir. And one more, there is a direct damage to lipid peroxidase enzymes, sir. So that also causes increased chance of stroke, sir.
Okay, ultimately it is the anaerobic glycolysis producing more lactic acid and oxidants that are produced, increased number of oxidants, oxidative stress ultimately it leads to, and lipid peroxidation. These three things by which it can enhance a stroke, existing stroke. So that's why what IV fluids are preferred in patients with stroke?
NS,
IV fluids. NS. We
NS,
always, that's why
normal
we give them NS or glucose, never glucose. Okay. Right. Thank you. Thank you.
Thank you. Thank you.
Next, Divya Tej.
Good morning, sir. Good morning, sir.
Good morning. Good morning, Dr. Divya Tejana.
Yes, sir.
So what is your study?
Sir, my study is risk factors and etiological profile of stroke in young, sir. Risk factors and
etiological profile of stroke in the young.
Yes, sir.
How many patients you have studied?
Sir, 50 patients, sir.
What do you? What is the cutoff point for the young stroke?
So 45 years, sir.
So less than 45 years.
Yes, sir. Less than 45
So what
years.
are the most common causes you may have made out?
In my study, sir, the mean age of presentation was 34 plus or minus 7 years, sir. Most of the patients were in the age of 34 plus or minus 7 years. And most of the patients had more than 2 to 3 risk factors, sir. Like they had hypertension, dyslipidemia, diabetes mellitus, history of smoking and alcohol intake, sir. And In my study, males were more affected, sir. Male predominance is seen, sir, compared to female.
Okay, another risk factor you made out is
Sir,
hyper.
Sir, in my study, the most study stroke of other determined etiology, the most common risk factor I have noticed is hypercoagulable disorder, sir. Under that, hyperhomocystinemia is the most common cause, sir.
How does hyperhomocystinuria lead to hypercoagulable state?
So actually, increased levels of homocysteine causes increased formation of blood clots. Sir. They are more prone to get embolic strokes.
Any mechanism? Okay, read about what is the mechanism. Okay. Then anyway, you also said in your conclusions also, regional wall motion abnormality is increased to stroke. In what way regional wall motion abnormalities on echocardiography increases the stroke? Is it an incidental finding or etiological factor? That's what I am going to.
Incidental.
Huh? It could be an incidental finding, not etiological factor as such. Simple regional wall abnormalities on echo in a patient with stroke. But what cardiac findings can suggest embolic stroke? Or what are the causes of cardioembolic stroke?
Atrial fibrillation.
Huh? One is atrial fibrillation.
Yes.
Two.
Valvular heart disease. Valvular heart disease.
Mitral valvular heart disease, especially mitral valvular heart disease. Okay. 3.
Rheumatic heart disease.
Regional wall motion abnormalities acutely can occur in which condition? Acute chest pain, acute myocardial infarction. Okay, regional wall motion abnormalities due to acute MI can lead to thrombus formation of mural thrombus, that is called, which can get dislodged and produce cerebral embolism. What is the fourth source? Fever associated with fever and embolisms. Cardiac patient with valvular heart disease, fever, embolism.
Endocarditis.
Huh?
Endocarditis.
Bacterial endocarditis. So all the for these things especially we seek the 2D echocardiogram to know about these concerns. Okay.
Thank you.
How is their recovery? Young patients.
Prognosis, those who presented with who had more than 2 to 3 risk factors, they arrive with poor prognosis, sir.
Poor prognosis means mortality or poor recovery?
Poor recovery, sir.
Poor recovery as far as the motor function is concerned.
Yes.
Okay. What is the usually most common site for cerebrovascular thrombosis?
At the bifurcation of the carotid.
Hemiplegia, causing hemiplegia. Which is the most common site? Which capsule?
Internal.
Which capsule is the most common site?
Internal capsule.
Internal capsule. Okay. Thalamo-geniculate artery supplying the internal capsule. ఏమైనా MDI నువ్వు మరి అది టకటక చెప్పాలి నువ్వు. ఓకే, థ్యాంక్ యూ. థ్యాంక్ యూ. ఓకే, థ్యాంక్ యూ.
Next APS 086 Avanapo Sucharita.
Internal capsule. Okay. Thalamo-geniculate artery supplying. Dr. Sucharita.
Ma'am, I
okay,
unmuted,
thank
ma'am.
you. Thank you. Okay, thank you.
Next,
please video, please.
APS 086 Avanapo Sucharita.
Sucharita. Anyway. Okay, what is your study, Sucharita? Internal capsule. Okay, thalamo-geniculate.
Sir, I'm Sucharita, sir. Ma'am, am I audible? Ma'am, am I audible?
Yes. What is your study?
Sir, my study is
Okay.
about, I have evaluated and
Next,
analyzed
this
the
video,
cases of neuromyelitis optica cases, sir, which presented to our hospital.
Avanapu
Sucharita. Sir, I'm talking, sir. Am I audible, sir?
Audible. No more announcements, please. We are audible. Okay, she is on
Yes,
screen.
sir. Sir, I'm continuing, sir. I evaluated and analyzed cases of neuromyelitis optica spectrum.
How many cases? How many cases?
5 cases
What
in
is your
9 months
study?
period, sir. My study is
Okay.
about, I have evaluated and analyzed the cases of neuromyelitis optica cases, sir, presented to our
Okay, what is NMO spectrum disorders?
Sucharita.
What is the other name for NMO?
Devic
సుచరిత
disease, sir.
సుచరిత
Another
సుచరిత
name is Devic disease,
సుచరిత
sir.
మీ దగ్గర నుంచి చాలా డిస్టర్బెన్స్ వస్తుంది
Yes, sir. Sir, I'm
చాలా
continuing.
డిస్టర్బెన్స్ వస్తుంది
I evaluated and analyzed cases of
ఎక్కడన్నా అది ఏదైనా ఎక్కడన్నా అది వీడియో ఏదైనా ఆన్ ఉంది దానికోసం చాలా
Sir, in 9 months
డిస్టర్బెన్స్
period,
వస్తుంది
sir, my study is about, I have evaluated and analyzed the neuromyelitis optica cases, sir, presented to our
Okay, what is NMO spectrum disorders?
Sucharita.
What is the other name for NMO?
Devic
సుచరిత
disease, sir.
సుచరిత
Another name
సుచరిత
is Devic disease.
సుచరిత మీ దగ్గర నుంచి చాలా డిస్టర్బెన్స్ వస్తుంది
Sir,
Devic
there
disease.
is nothing nowhere around me, sir.
మేడం మీ దగ్గర నుంచి ఒక వీడియో ఉంది కదా యూట్యూబ్ అది ఓపెన్ ఉంది
Now disturbance is over, Sucharita. Now clear. Am I audible, Sucharita?
yes sir you are audible
Dr. Sucharita only. There is a lot of noise now. Only Sucharita. Hello.
please unmute madam please unmute
Aye.
don't share screen no. please unmute
Hello, Sucharita.
Now I'm audible, sir.
Yes.
Yes, sir.
Okay, ma'am. So, NMO spectrum disorders. So, what is meant by spectrum disorders?
please unmute
What is
madam.
NMO? What is NMO spectrum disorders?
don't share screen no.
Sir, these will also include
please
neuromyelitis.
unmute
Sir, I have already unmuted, sir. Am I audible, sir, now?
Audible, Sucharita.
Sir, now I'm audible, sir. Under NMO spectrum
yes.
disorders, there will be also some partially presented disorders which have clinical presentation.
NMO spectrum disorders.
Yes, sir.
Sucharita wait Sucharita
Spectrum disorders.
Sir,
What is NMO? What is NMO
Sarma
spectrum
sir
disorders?
in your laptop
Sir,
there is one video
NMO
is
spectrum
running.
disorders along with neuromyelitis
YouTube.
optica, there will be other disorders which have partial presentation as NMO and also some presentations which have involvement of other areas in the central nervous system. There will be also some like hypothalamus, brainstem, and cerebral presentation.
Sir please unmute Sarma sir please unmute yes sir
చేసావా
yes sir
Unmute అంటున్నాడు.
yes sir thank you
Okay. Shall I unmute?
yes sir it is perfect
Sir, am I
Now
audible,
it's
sir, now?
okay.
yes sir
Okay. Okay, Dr. Sucharita.
Sarma sir please unmute
Unmute.
yes sir
Hello, Dr. Sucharita.
Yes, sir. I'm listening, sir.
yes sir
Yes,
sir thank you
Okay. What is the antigen antibody that is implicated in NMO disorders?
yes sir it is perfect
Sir, aquaporin 4
Now it's
antibodies.
okay.
yes sir
So why is optic nerve so frequently involved in NMO disorders?
Sir, in NMO disorders,
yes sir
sir, unlike in multiple
Dr.
sclerosis
Sucharita.
where sensory involvement
Yes,
is
sir.
predominant,
Yes,
in
sir.
NMO
Yes, sir.
disorders, there will be
Yes, sir.
optic
Yes, sir.
neuritis and severe myelitis which
Okay.
will be presented
Okay, is
predominantly,
the
sir.
antigen antibody
And
that is
optic neuritis
implicated in NMO
also
disorders?
bilaterally
it is
presented,
perfect.
sir. Sir, In aquaporin 4
Now it's
antibodies.
okay.
yes sir
So why is optic nerve so frequently involved in NMO disorders?
Sir, due to extensive cord involvement, sir. Sir, unlike in multiple
Dr.
sclerosis
Sucharita.
where sensory involvement is predominant,
Yes,
in
sir.
NMO disorder, there will be
Yes, sir.
optic
Yes, sir.
neuritis and severe myelitis which
Okay.
will be presented
Okay, is
predominantly,
the
sir.
antigen antibody
And
that is
optic neuritis
implicated in
also bilaterally
Yes, sir.
presented, sir. In number four
now it's
antibodies.
okay.
Yes, sir. Yes, sir. Yes.
So why is the audio మళ్ళీ
Hello,
వస్తుంది
Madan.
మళ్ళీ
It is
involved in
అదే ఆడియో మళ్ళా వస్తుంది
Sir,
మదన్.
due to extensive cord involvement, sir.
ఆడియో రిపీట్
ఇదిగో.
అవుతుంది ఉండమ్మా వెయిట్
అదే.
వెయిట్ ఫర్ 2
In
minutes.
NMO disorder, there will be
Yes, sir.
optic
Yes, sir.
neuritis and severe myelitis which will be presented
Okay, is
predominantly,
the
sir.
antigen antibody
And
that is
optic neuritis
implicated
also bilaterally presented, sir.
బై మదన్ లినోవో ల్యాప్టాప్ సుచరిత ల్యాప్టాప్ లో చెక్ చేయి సార్ ల్యాప్టాప్ లో ఏం ప్రాబ్లం
ఆడియో
ఓన్లీ లినోవో ల్యాప్టాప్ లో అదే ఆడియో మళ్ళా వస్తుంది మదన్.
Due to extensive cord involvement, sir.
ఆడియో రిపీట్ ఇందాక ఆల్రెడీ అడిగిందే రిపీట్ అయిపోతుంది ఇప్పుడు
హలో
ఇప్పుడు ఓకే అమ్మా ఇప్పుడు రిపీట్ అవుతున్నా
Sir, it is still repeating, sir, on the background.
మదన్ లినోవో ల్యాప్టాప్ ప్రాబ్లం ఓన్లీ లినోవో ల్యాప్టాప్ లో అదే ఆడియో మళ్ళా వస్తుంది మదన్.
Due to extensive cord involvement, sir.
ఆడియో
ఒకసారి మీ సిస్టమ్ లో నుంచి చూడండి.
ఇగో మదన్ ఇప్పుడు క్లియర్ వస్తుంది.
సుచరిత గారు మీరు 2 సిస్టమ్లు ఓపెన్ చేశారా ఏమైనా? అన్మ్యూట్ చేయండి. అన్మ్యూట్
అదే ఆడియో మళ్ళా వస్తుంది మదన్.
Due to extensive cord involvement, sir.
ఆడియో
ఒకసారి మీ సిస్టమ్ లో నుంచి చూడండి.
ఇగో మదన్ ఇప్పుడు క్లియర్ వస్తుంది.
సుచరిత గారు మీరు 2 క్లియర్ రావడం లేదు అట్లా ఏమైనా?
లేదు, sir.
మళ్ళీ
లేదు,
రిపీట్ అవుతుంది.
లేదు, sir. ఓన్లీ ల్యాప్టాప్ ఉంది, sir.
అన్మ్యూట్ చేయండి. అన్మ్యూట్
Okay.
సుచరిత మేడం క్యాన్ యూ రీజాయిన్ ఒకసారి మొత్తం డెస్క్టాప్ ఉంది కదా మొత్తం షట్ డౌన్ చేసి మళ్ళీ ఆన్ చేసి
ఒకసారి జాయిన్ కండి మీరు ప్లీజ్.
Sir,
సుచరిత గారు మీరు 2 క్లియర్ రావడం లేదు అట్లా ఏమైనా?
లేదు, sir.
మళ్ళీ
లేదు,
రిపీట్
sir.
అవుతుంది.
లేదు, sir. ఓన్లీ ల్యాప్టాప్ ఉంది, sir.
అన్మ్యూట్ చేయండి. అన్మ్యూట్
సార్ శర్మ సార్ క్యాన్ వి గో నెక్స్ట్. హలో మదన్
కెన్ వి గో నెక్స్ట్?
డెస్క్టాప్ ఉంది కదా మొత్తం షట్ డౌన్ చేసి మళ్ళీ
Okay, I'll rejoin again. I'll rejoin.
You rejoin again. Yes, you rejoin again. సుచరిత గారు మీరు 2 క్లియర్ రావడం లేదు అట్లా ఏమైనా?
లేదు, sir.
We'll call you once again అండి.
లలిత ప్రసాద్. హలో
లలిత ప్రసాద్ సార్.
Sir, am I audible, sir?
Yes. Can your video is on?
Sir, 1 minute. Sir.
Please start your video. Your abstract number is ABS 09.
Yes, sir.
Okay, Sarma sir, you can start, sir.
ఓకే హలో డాక్టర్ లలిత్
Sir.
Lalita
Sir, good
Prasad.
morning, sir.
Good morning.
Yes, sir.
Good morning. So what is
Good
your
morning,
study?
So my
What
study
is
is on
your
the
study?
cardiac evaluation of the cardiac evaluation of the patients with ischemic cerebrovascular disease patients, sir. Sir, am I audible, sir?
Yes. So what are your cardiac findings? Cardiac evaluation means?
Sir, out of the
What is the purpose of evaluating heart?
Sir,
What is the purpose of evaluating the heart in a
to
patient
know
with
about
stroke?
to know about the cardioembolic causes contributing to the ischemic cerebrovascular disease, sir. And if they can be identified and prevented,
So what
we
are
can
the
prevent this, sir. Yes, sir.
Okay. So what are the causes of cardioembolism?
Sir, atrial
Causes
fibrillation,
of
sir.
cardioembolic stroke.
Sir, ischemic heart disease, sir.
Okay.
And mitral stenosis, ischemic heart disease, sir.
Okay. Which part of the ischemic heart disease? Acute or chronic?
Acute. chronic ischemic heart disease, sir.
Which type of, okay.
Sir.
Huh? Hello.
Sir,
Lalit,
am
you
I
are not
audible, sir?
Hello,
audible.
Dr. Prasad.
Yes.
Yes, sir. Am I audible, sir? No.
Your internet is not stable, Lalit.
Sir.
Yeah, now it is well.
So.
Okay, hello, Dr. Lalit Prasad.
Sir, am I audible, sir? Yes, sir.
Hello.
Yes, Lalit. Yes, Lalit.
Okay, what are the other causes for?
Sir.
In
Sir, voice is breaking, sir.
ischemic stroke, only acute, in acute MI only, or
Sir.
in a chronic severe congestive heart failure where there is severe left ventricular dysfunction. Also, mural thrombi can form and cardioembolic stroke can occur. What are the other causes associated with fever? Fever,
Sir,
cardioembolic stroke.
Infective endocarditis, sir.
Infective endocarditis. Okay.
Yes, sir.
Okay, any other valves?
Sir, any non-bacterial
Artic-
thrombotic endocarditis, sir.
Oh, okay. Any
Yes, sir.
valves? Artificial
Yes, sir.
valves
Prosthetic
where
valve, so
thrombus
valve
can form
replacement,
and
sir.
with
Mechanic valves,
inadequate
sir.
mechanical valves with
Anticoagulation, sir.
inadequate anticoagulation.
Coagulation, there is
Also
chances
can
of
lead to
formation.
cardioembolic stroke.
Cardioembolic stroke, sir.
Yeah, neuroradiologically, when do we say cardioembolic stroke? It is embolic stroke, not ischemic. Thrombotic stroke. Because you have studied, you might have seen so many CTs also.
Yes, sir.
So CT wise, when do they say, when do the radiologist will say this is embolic stroke, sir, not ischemic, not thrombosis?
Sir, when the individual territory of the vessels are involved, sir.
Huh?
Territories of the blood vessels will be involved in embolic stroke, sir.
So one is multiple
Yes, sir.
simultaneous occurrence of multiple infarcts. So because showers of emboli can occur, they can enter various vessels. That is one thing. And infarct with hemorrhagic transformation, or even much more subcortical, etc. Infarcts with hemorrhagic radiological. Okay, what is the treatment for embolic stroke? Specific treatment for embolic stroke.
Sir, first we have to treat the primary cause, which is causing the cardioembolic stroke, sir.
Primary cause, okay, apart from primary cause treatment, what else specific treatment is given in a embolic stroke?
Sir, heparin is given, sir.
Anticoagulants, injectable anticoagulants, heparin,
Anticoagulants,
or
low
low
molecular
molecular weight
heparin, heparin, sir.
Initially,
Sir, our voice is not audible, sir.
5 to 7 days.
Yes, sir.
Okay, thank you. Thank you.
Thank you, sir.
Thank you. Next.
Hello. Next.
Huh?
Hello.
Sriram.
Hello, sir. Sir, am I audible?
Yes.
Good morning, sir. Hello.
Yes. Hello, Dr. Sriramya.
Sir,
Hello,
good
Dr.
morning,
Sriramya. Hello. What is your study?
Sir, my study is on overview of Guillain-Barré syndrome with reference to clinical features and prognostic outcomes, sir.
So, what are the routine clinical features you have observed or when
I have studied in 50 patients, sir. They have presented with various features like
Guillain-Barré.
I have studied in 50 patients, sir. Out of 40,
what clinical
out of
features?
50, 42 patients had weakness of both upper and lower limbs, sir. And 15 of them had neck muscle weakness. And 8 patients showed features of bulbar weakness, sir, of 2 having ocular muscle involvement, sir.
So,
15 patients showed sensory disturbances, sir. Hello, sir. Hello.
they will have both, of course, but which is
Sir, not audible, sir. Hello.
Wait, madam, wait.
hello,
Hello.
Dr. Sriramya.
Sir, audible, sir.
Hello,
Hello, sir.
Dr. Sriramya, are you able to hear me?
Yes, sir.
Video రావట్లేదు అమ్మాయిది
Please start your video.
Video,
Ramya.
amma.
Hello.
Ramya,
Ramya.
please start your video also.
Sir,
Hello.
am I
Hello, Sriramya.
sir?
Please come on to the screen also, please.
Am I visible, sir?
Okay. Okay, in Guillain-Barré syndrome, which muscle involvement is much more common, proximal or distal? Which more severe?
Proximal muscle weakness is more common, sir. More severe. Proximal more than distal, sir.
Usually, okay. You said bulbar muscle paralysis. Involvement. What symptoms they will have?
The patient had difficulty in swallowing, sir, with upper bulbar weakness, and they had weakness in the difficulty in there is pooling of secretion, sir, of which the patient are intubated, sir.
Why there is pooling? That means weakness of which muscle? Swallowing.
Bulbar muscle weakness, sir.
There is difficulty, dysphagia.
Dysphagia and
dysarthria.
Dysarthria.
Nasal
Cranial
regurgitation.
nerve.
These 3 features will suggest bulbar involvement. Okay. Right. What are the autonomic dysfunction? You said some have autonomic dysfunction. What are the features of autonomic dysfunction?
They had bladder
Symptom-wise.
incontinence, sir. Incontinence of bladder.
Okay. Next, only bladder.
They presented only with the urinary incontinence, sir.
I mean, what are all the other features of autonomic dysfunction?
Sir?
Other features of autonomic dysfunction.
Autonomic involvement.
Other features of autonomic dysfunction. Other signs
Abnormal.
and symptoms of autonomic system involvement.
abnormal sweating and cardiac dysautonomias, cardiac arrhythmias, hypotension. This can also have, sir.
Which hypotension? Which hypotension?
Hypotension.
Postural hypotension.
Postural hypotension, sir. Yes, sir.
And hypertension can also occur. Can hypertension also occur in autonomic dysfunction?
It can occur.
Yes, it can also
can
occur.
occur.
So sudden hypertension in patients with Guillain-Barré syndrome is due to autonomic dysfunction.
Yes, sir.
Okay. Apart from bladder symptoms, what you have said. Okay, right. So how do you diagnose?
Along with the normal CBC and all the routine blood test, I have done the CSF analysis and electrodiagnostic studies, sir.
What is
In CS
albuminocytologic dissociation?
there will be elevated CSF albumin, sir, without any pleocytosis, sir.
What are the other causes of albuminocytologic dissociation?
It can also be seen in various conditions like tumors, encephalitis, spinal compression.
What tumor? Where?
Intracranial tumors.
Extramedullary tumors.
Extramedullary tumors.
What is Freund's syndrome? Freund's syndrome.
Freund, sir.
Ah.
It is the extramedullary compression with pleocytosis and
Not pleocytosis.
some lesions are abnormal.
The CSF, yellow, high-colored CSF
Yellow
due to very high albumin,
Albumin.
very high protein content, but no cells. That is also a type of albuminocytologic
Cytological
dissociation. Okay. What is the treatment of Guillain-Barré syndrome?
Early age of in the early presentations, we can give the plasmapheresis and intravenous immunoglobulin, sir. 2 grams per
What is the
kg.
dose of intravenous immunoglobulin?
2 grams per kg body weight, sir.
In 2 grams single day?
No, sir, over 4 to 5 days.
Over 5 days. Over 5 days. Okay. Okay. So what is plasmapheresis?
Plasmapheresis, it is the plasma exchange of 40 to 50 ml per kg. For 4 to 5 times it can be done. Or
Okay,
7 to
thank
10
you.
days.
Okay, thank you, Dr. Ramya.
Thank you.
Next, Sucharita. Hello, Sucharita. Hello, Sucharita.
Sucharita.
Madam, Sucharita also there, madam.
Patad. Salla Sri Kirti వచ్చాడు కదా.
Yes, sir.
Salla Sri Kirti, your name?
Yes, sir.
So
Good morning.
what is your study, Amma? Good morning, Talli.
Sir, my study is blood glucose level as an independent predictor of outcome in acute ischemic stroke, sir. Sir, here we have studied 100 patients who presented with acute ischemic stroke, and we have recorded their blood sugar at admission, sir. We have tested their GRBS, and we have divided the patients into being normoglycemic and hyperglycemic, sir. And we have followed up those patients at 90-day interval to see their stroke severity, sir.
Okay. So anyway, your presentation is usually the time given to 6 minutes, but you have taken 9 minutes per presentation. So you must learn to cut down. So what are the unnecessary things? You must edit it to 6 minutes. Because anyway, here we have accepted, but in some other scientific fora, they will not accept you. They will stop you and say disqualify you.
Yes, sir.
So also learn that aspect. Then how do you distinguish whether it is stress hyperglycemia or diabetes mellitus?
Sir, in these patients, stress hyperglycemia is also common, sir. So to differentiate, we have done HbA1c in all these patients, sir, who had hyperglycemia. In patients,
so how many of
prior
them?
in patients who had prior history of diabetes, we haven't done, sir. But in patients with no prior history, we have done HbA1c for all the patients, sir, to differentiate, sir.
So how many of you have got stress hyperglycemia?
Sir, in this study, out of 154 patients had hyperglycemia, sir. Out of them, 20 had stress hyperglycemia, sir.
That means their HbA1c levels are normal.
But normal, sir. Yes, sir.
How is their prognosis?
Sir, when compared to people with normoglycemia, people with hyperglycemia had a poorer prognosis at 90-day follow-up, sir. Among these patients also, people with stress hyperglycemia had a poorer prognosis, sir. Among diabetics, people who had known diabetes, that is with prior history of diabetes, had a has a better prognosis than people who were detected at that time of stroke, sir.
That is also finding in your study. Okay.
Yes, sir. Yes, sir.
Okay. How does hyperglycemia adversely affect the stroke outcomes?
Sir,
What way?
hyperglycemia it can cause direct tissue injury because of the anaerobic glycolysis, sir. Also, in diabetics, there is a increased tendency to thrombosis, sir. There is increased thrombin and decreased platelet activation inhibitor, sir. So diabetics are more prone to thrombotic stroke when compared to the remaining population, sir.
Even stress hyperglycemia, you said, is associated with poorer prognosis.
Yes, sir.
So what is the other mechanism? One is anaerobic glycolysis.
Also, there is oxidative free radical mediated tissue damage.
Free radical mediated tissue damage and oxidative stress is much more in with hyperglycemia. That's why what fluids do you suggest in stroke, ischemic stroke?
Sir, the preferred is normal saline only, sir.
Normal saline only. That's why we try to avoid always dextrose in patients with stroke, ischemic stroke. Okay. How do you treat ischemic stroke?
Sir, once the diagnosis of ischemic stroke is confirmed, we start the patient on antiplatelets and statins, sir. And also, if the patient comes to us within the window period and if it's a thrombotic stroke, we plan.
What is the window period? How much is the window period?
Sir, within 4 hours, sir.
And what other criteria? CT. CT should not show.
CT should not show any hemorrhage, sir.
Hemorrhage.
And the patient
Then what drug is given?
Sir?
What drug is given for thrombolysis?
So tissue plasminogen activators are given, sir.
What is the dosage? So you must be prepared with these questions because you have made a study. You must thoroughly read all these things. Okay. Anyway, thank you. Thank you. Okay.
Thank you.
Next, Venkata Purnima. Venkata Purnima.
Sir.
Please start your video. Okay.
Started.
Good morning, Venkata Purnima. What is your study?
So my study is a study of 50 cases of cerebral venous thrombosis in adult women, sir.
How did you suspect cerebral venous sinus thrombosis?
So I have taken
Why not arterial thrombosis? Why not arterial thrombosis?
already diagnosed cases I have taken, sir.
Clinically, when do you suspect? That's what I am asking.
Headache, sir. Severe headache.
Severe persistent headache. The headache doesn't subside in 2 or 3 days also, still they continue to complain.
Yes, sir.
Okay, next.
Next followed by seizures, sir.
Seizures.
Seizures is the most
So
common.
usually in arterial ischemic strokes, usually we don't find them with seizures. So if any stroke with severe headache and seizures, so we must and symptoms of ICT, we must suspect venous sinus thrombosis. And then of course go for neuroimaging, neuroradiological imaging, which will be confirmatory. Which is the confirmatory one?
MRV, sir. Magnetic
MRI. What signs will occur in cortical venous sinus? What are the various signs described?
Cord sign, MP, delta sign. Cord on MRV we'll get delta sign.
CT or MRI, neuroimaging. What are the various signs described in relation to cortical CVT, that is cortical venous sinus thrombosis?
In CT we'll get cord sign, empty triangle sign, and the delta sign, sir, on MRV.
Delta sign. What is delta sign?
Superior sagittal sinus thrombosis, sir. A triangle density.
So what type of motor paralysis can occur in superior sagittal sinus thrombosis? sometimes.
Hemiparesis, sir. Hemiparesis.
Hemiparesis any మామూలుగా any stroke అంట కానీ superior sagittal sinus thrombosis is abating the it is draining the both leg areas paralateral. So it is one of the central causes for paraplegia. Understand? Paraplegia can occur. Superior sagittal sinus thrombosis. What are the other central causes for paraplegia? These are called central causes for paraplegia.
Meningioma, parasagittal meningioma.
Parasagittal meningioma. And which artery thrombosis?
ACA artery thrombosis, sir. Anterior cervical artery.
ACA is bilateral. It is. How does it produce unilateral? I mean, it is a bilateral normally. Anterior cerebral artery. Two cerebral arteries are there. ACAs. How does it produce bilaterally? When it is unpaired. That is called unpaired anterior cerebral artery. So unpaired anterior cerebral artery thrombosis, venous thrombosis, and parasagittal meningiomas. All these three are more common central causes of paraplegia. Okay. So you must know as a postgraduate all these things. Okay, what is the treatment for CVT?
CVT anticoagulants, sir. Heparin, low molecular or unfractionated heparin.
Heparin dosage.
80 microgram per kg or 18 microgram per kg infusion, sir. Directly
Micrograms, micrograms, heparin milligrams.
Milligrams.
Both are same. సరిగ్గా చూడు డోస్ మళ్ళీ చదువు డోస్ ఆఫ్ heparin చదువు మరి దాని మీద డిసర్టేషన్ చేయాలి. ఐ మీన్ ప్రజెంట్ చేసిన దాన్ని యూ మస్ట్ రీడ్ థరోలీ. ఏదైనా అడగచ్చు దీంట్లో అని. యూ మస్ట్ బి ప్రిపేర్డ్. ట్రీట్మెంట్ ఏంటి, ఇదేంటి, ఏ సైన్స్ ఈచ్ ఇంకా అడగలేదు నేను అన్ని. ఈచ్ వెనస్ సైనస్ థ్రాంబోసిస్ క్లినికల్ సైన్స్ అడగచ్చు. కెవర్నస్ సైనస్ థ్రాంబోసిస్ ఏముంటాయి క్లినికల్ సైన్స్?
3, 4, 6 nerves involved.
Nerves and proptosis and edema of eyelids. They present with the edema of eyelids, blurring of vision, 3, 4, 6 nerves. So you must suspect clinically cavernous sinus thrombosis. So likewise, anyway. Thank you. Okay, thank you.
Next, Narayanamma. Hello.
Yes, sir.
Abstract number 203.
Yes, sir.
Please start your video.
Please start your video, madam. Dr. Narayanamma.
Sir, good morning.
Okay. What is your study, Dr. Narayanamma?
Serum uric acid is an independent risk factor in acute ischemic non-embolic stroke, sir.
Serum uric acid as an independent risk factor in acute ischemic stroke.
Yes, sir.
So how many cases you have studied?
100 cases I have studied, sir.
And how many of them uric acid is high?
In among them, 25 patients have high uric acid levels, sir. That means more than 7
What is the
milligram per
cutoff level
deciliter.
you have taken? What is the cutoff level?
More than or equal to 7 milligram per deciliter, sir.
Okay. In what way that is related to stroke?
Uric acid, usually it is a pro-oxidant, sir, antioxidant, sir, normally.
Antioxidant.
Yes, sir. But when there is levels more than or equal to 7 milligram per deciliter, it acts as a pro-oxidant and it causes endothelial damage, sir, which results in coagulation cascade initiation, resulting in thrombosis, sir. That may lead to ischemic strokes.
What does usually it causes? Hyperuricemia. What are the more common manifestations?
Gouty arthritis, sir. Pain in
Gouty
the first
arthritis.
metatarsal joint. Tenderness and
Renal?
swelling is there, sir.
Any renal manifestation?
Nephropathy will be there, sir. Urate nephropathy, acute urate nephropathy.
Before that, sometimes caliculi, uric acid
Yes, sir.
caliculi.
Uric acid caliculi also.
Then nephropathy.
Yes.
Does it directly induce thrombosis anywhere there?
No, sir.
You have proposed a mechanism anyway. Okay. That's okay. Right. So, how many of your patients improved well?
Actually, I have done a cross-sectional study, sir. That's why I haven't followed up this.
Oh, only cross-sectional study,
Yes.
not follow-up
Yes,
observational study. Okay,
Yes.
sir. Then how did you correlate? If suppose if it is high in 25, in what parameter it correlated with?
Mostly these are old age patients, sir, and patients with diabetes and patients who have CAD and developed acute ischemic stroke. These uric acid levels are high, sir. So whenever we are seeing the case with the high elderly, high older age patients or diabetes or CAD patients, we have to, if we measure the serum uric acid levels and we take the measures like we can decrease the diet rich in uric acid levels or prescribing some uric acid, if the patients having any alcohol consumption history, then we should we should stop asking them to stop alcohol intake or some drugs like eloprenol or febuxostat. If we decrease the serum uric acid levels, then we decrease the risk of stroke in them, sir.
Suppose if you decrease the serum uric acid level, do you think they will completely recover and go
No,
away
sir.
home?
No,
Go back
sir.
home?
But other parameters also we have to consider.
Also important. Okay.
Yes.
Thank you.
Thank you, sir.
Parenti Sabarish Kumar.
Next,
Sabarish.
Sriteja. Sir, one is skip, sir.
Oh.
Sriteja Garimilla.
Sir. Sir.
The abstract number is serial number is 13, sir.
13. What is your study? What is your name?
Sir, good morning, sir. My name is Dr. Sriteja, sir.
Venkat Sri Teja. Yes. So what is your study?
Mine is a study of relationship between non-HDL cholesterol and severity of stroke, sir.
How many patients you have studied?
100 patients, sir.
How many of them non-HDL is high?
Out of them, 39 patients had severe stroke. In 39 patients, in 31 patients, sir, 31 patients had severe stroke.
As per which scale?
Sir,
Severe, how did you say severe or mild? NIH scale.
NIH stroke scale, sir. So according to that, 31 patients had severe stroke. Average non-HDL cholesterol levels of those 31 patients with severe stroke was 164 milligrams per deciliter, sir. So in
what way non-HDL related to stroke? What is non-HDL? What is the significance?
Sir,
when there is a, suppose when there is a total cholesterol, LDL is there, HDL is there, then what is the significance of non-HDL? So nowadays they say for everything non-HDL also. What is its significance?
Mainly.
So non-HDL, that means HDL contains which apolipoprotein and LDL and other what apolipoprotein they contain?
ApoA lipoproteins.
So ApoA is in HDL. That is supposed to be protective or a good cholesterol. What we say is, whereas non-HDL means all other the entire cholesterol which doesn't have this alpha lipoprotein have other lipoproteins. I mean apolipoproteins, beta apolipoproteins, etc., which are heterogenic. They are heterogenic. But whereas HDL is not heterogenic, that's why it is not only simple total cholesterol, LDL and HDL, but non-HDL is also equally important. What is the level, suggested level that it should be?
It should be less than 130, sir.
Less
130.
than 130. That spot is okay. Okay. So, how did they fare your patients with high non-HDL? What is the, in your study, what happened to them?
In patients with high non-HDL cholesterol levels, all of them had severe stroke, sir.
Severe stroke is much more common in them. Okay. Compared to whose non-HDL is low or less than 130.
Yes, sir.
Is it? And prognosis anyway. So even for a short period only, it was observational study.
Yes, sir.
Not follow-up.
No,
Okay.
no, sir, not follow-ups.
So what is the treatment for this non-HDL, high HDL?
Sir, treatment for non-HDL cholesterol, statin, sir, statin therapy, sir.
So what is the dose of statins that is preferred in stroke, in acute stroke, acute situation?
In acute situation, the dose of statins are atorvastatin 80 mg, sir. 50 to 80 mg per day.
Rosuvastatin?
Rosuvastatin is 20 to 40 mg per day, sir.
Okay. Then what else can also be given along with, suppose if it doesn't decrease with these two alone, what other drug can be added to this?
Fibrates, sir.
Which decreases absorption of cholesterol. Fibrates, they act more on triglycerides.
Triglycerides.
Not on cholesterol. Ezetimibe. So statin plus ezetimibe can be given if it is high, which will much more rapidly decrease the non-HDL cholesterol levels. Okay. So what is the most common site of, presentation in these strokes? What is the most common presentation clinically in your study?
Most common presentation is hemiplegia, sir.
Hemiplegia.
Yes, sir.
So where is the lesion in hemiplegia most common site?
Most common is MCA territory, sir.
MCA territory, which part of the brain? Not artery, I am asking which part of the brain?
Cerebral.
Is it brainstem, internal capsule, motor cortex? Where it is most common site for hemiplegia? Internal
capsule, sir.
Internal capsule is the most common site, which is supplied by middle cerebral artery. Okay. Which artery specifically? Which branch? Thalamo-geniculate artery of middle cerebral artery is the most common site for cerebral thrombosis. What is atherosclerosis? What is arteriosclerosis? Arteriosclerosis ante enti? Sclerosis ante thickening. Thickening of the arteries. Thickening of the arteries most common cause is atherosclerosis. Atherosclerosis ante enti? Deposition of what we call it as atherosclerosis? Which substance?
Cholesterol.
Carbohydrates, proteins, lipids, ఏమి డిపాజిట్ అయితే అంటాం atherosclerosis?
Lipids, sir.
Lipids. So it is the oxidized LDL which gets deposited. Lipids that initiates and propagates the atherosclerosis. Atherosclerosis is the most common cause for arteriosclerosis.
Yes,
arteriosclerosis can also occur due to other causes like calcification of an artery. That can also produce arteriosclerosis. Von-Koberg's medial sclerosis. There is sclerosis, thickening of the artery. So there could be other causes. The most common cause is atherosclerosis. Okay.
Yes,
so atherosclerosis is the, because you should know about everything about atherosclerosis, please read about it, because it is the atherosclerosis which is causing devastating our entire arterial tree, brain, cerebrovascular accident, myocardial infarctions, renal infarctions, peripheral vascular disease. Everything is due to atherosclerosis.
Yes,
so you
sir.
should know everything about atherosclerosis. Read
Yes,
about it. Okay, thank you.
Thank you, sir.
Thank you.
Thank you, sir.
Okay, thanks.
Hello. Next abstract number 224. Subharish Kumar. Hello, Subharish Kumar.
Dr. Triveni Venkata Chaudhary.
Sabarish Nadutunaru. Ikkada unnada? Okay, Sabarish Kumar will join later. Now, next number. Abstract number 228.
Sir, can we do Sucharita? The
back Sucharita, number 6.
Serial number
Sure,
8.
Serial number
Sucharita.
6 or 8? 8 Sucharita.
8, sir.
Oh, my question.
Ma'am,
Hello,
sir,
Dr.
she's came.
Sucharita.
Sir, good morning, sir.
Good morning. Now audio is clear.
Yes, sir.
Okay, now audio is clear.
Yes, sir.
Oh. Sir, why I am asking is only one question, that is why in multiple compared to multiple sclerosis, NMO disorders, why optic nerve is more frequently involved? You know, చదివేసి ఉంటాను. Because ఏముంటాయి యాంటీజెన్ ఏంటి?
Sir, not.
యాంటీజెన్ ఏంటమ్మా చెప్పింది NMOలో?
Sir, aquaporin 4 antigen is antibodies against
antigen is wherever it is rich, those segments are more frequently involved. That's why the optic nerve and the
nerve is more commonly involved, sir. And bilateral involvement of the optic nerve is seen, sir.
Okay. Neuroradiologically, NMO,
yes, sir.
it is suspected.
Sir, if there is extensive longitudinal involvement of the segment, sir, 3 or 4.
This is like transverse myelitis.
Greater than 3.
Very good, very good. At least 3 or 4 segments longitudinal involvement, that we call it as transverse myelitis. So how do you differentiate transverse myelitis from Guillain-Barré syndrome? Both are acute presentations, acute paraplegia, acute quadriplegia can occur.
Sir, transverse myelitis from GBS, sir. Sir, in transverse myelitis, there will be very prominent cord segment distinguishing from the other areas, sir.
Clinical.
Sir, there will be transverse section, no, sir. There will be particular cord.
Transverse myelitis and the Guillain-Barré and then.
Yes, sir.
Clinical ga sensory. Transverse myelitis ఉంటుందో transverse level of sensory involvement ఉంటుందా? Transverse level of sensory involvement. Whereas Guillain-Barré లో sensory ఉంటుందా? ఉండదు. Second, bladder and bowel involvement transverse myelitis లో ఉంటుందా? Will be very early. అంటే retention of urine is one of the early symptoms in transverse myelitis.
GBS, sir. Yes, sir.
In GBS, it won't occur usually.
Yes, sir.
So bladder involvement and transverse level of sensory involvement, clinical ga దాన్ని బట్టి మనం transverse myelitis అంటాం. Okay.
Yes,
because
sir.
in acute phase there is hypotonia, loss of reflexes, and
yes,
only plantar may be extensor,
yes, sir,
even no response
shock,
also,
sir.
even in transverse myelitis. Just like in
Sir,
Guillain-Barré.
initially, sir, due to spinal shock, there might be hyporeflexia, no, sir. But after recovering from that, there will be a human
reflexia and bladder and bowel involvement. Yes. Those two suggest transverse myelitis. Okay.
Yes, sir.
Agreed or no?
Yes,
any
sir.
specific treatment for NMO disorders?
Not much different from the multiple
specific
sclerosis,
treatment
sir.
for NMO disorders?
Sir, no specific, not much different from the multiple sclerosis, sir. Even at there and here also, for acute presentation, we will be giving steroids, sir, 1 gram per day for at least 5 to 10 days, followed by steroid tapering, sir. And to prevent the relapses, we will be adding some immunomodulators, sir. These are not much studied. These disease-modifying therapies are not much studied in NMO, sir, as they are studied in multiple sclerosis. But Most commonly used prophylactic medications are
Steroids
mycophenolate
and-
mofetil, sir, and anti-CD24 antibody rituximab. Or if azathioprine has to be given, it should be mixed with the steroids, sir. Its dose should be 1 gram per kg. It is the prophylactic dose, sir. Along with azathioprine, it has to be given, sir, to prevent relapses as a prophylactic therapy.
Wait, ma'am. Yes, start, ma'am. Start, ma'am. Sir, please unmute, sir. Sarma sir, please unmute. Sarma sir, please unmute. Yes,
Okay.
Yes, sir.
Please unmute అంటున్నారు. Unmute లోనే ఉంది. Unmute లోనే ఉంది.
Yes, sir. It is perfect now.
Okay. Okay, Dr. Sucharita.
Sir.
Hello.
Sir. You are audible, sir.
So what is the treatment? Treatment ఒకటి చెప్పు. Okay, treatment ఏంటమ్మా చెప్పు.
Sir, for acute presentation, we'll treat with steroids, sir. 1 gram per day. They should be given at least 5 to 10 days. Or plasma exchange also can be done, sir. Plasma exchange in the frequency of 1.5 plasma per 1 exchange, sir. This is also should be done for 5 to 10 days. And it is followed by prophylactic management to prevent the relapses, sir. For prophylactic management, most commonly used immunomodulators are mycophenolate mofetil, sir. And anti-CD24 antibody rituximab, sir. Or if azathioprine has to be given, it should be steroids, sir. 1 gram per kg.
Okay, thank you. Enough. Thank you. Okay, thank you. Thank you.
Next, abstract number 228. Name Venkata Chaudhary. Venkata Chaudhary. Hello, Venkata Chaudhary. Ma'am, Venkata Chaudhary is not there. And next, Lingappa. Hello.
Next.
Lingappa. Abstract number ABS 239.
239
Lingappa.
Sir, not there, sir. Bhuvia.
Hello, Lingappa. Okay,
Bhuvia.
next.
Bhuvia.
Good morning, sir. I'm Bhavya, sir.
Please start video, ma'am. So, serial number 19. Sorry, this is.
Yes, sir. I'm Bhavya, sir. Peruri Bhavya, sir.
Hello, good morning, Amma. Dr. Bhavyana.
Yes, sir.
Okay, what is your study, Bhavya?
My study is regarding the prognostic significance of ferritin in acute ischemic stroke, sir. In our study, we took 55 patients, sir, with new onset acute ischemic stroke within 48 hours, sir. And we measured their serum ferritin levels, sir. We followed the patients after 4 weeks and calculated the Glasgow outcome scale, sir. Based on their disability, we calculated the outcome and whether the ferritin correlates with the outcome of the patient.
So, what is the normal serum ferritin?
Normal value.
What is the normal range?
30 to 300 nanograms per ml, usually. Little variation between lab values, sir. Around less than or equal to 300 is usually considered normal.
Okay, in what way serum ferritin is related to stroke? Is it the cause or the effect?
It is the
Is the high
cause, sir.
serum ferritin causing stroke or serum ferritin is high because of stroke?
No, sir. Serum ferritin causes high stroke, sir. Ferritin is the storage of iron form, sir. Because of it during ischemia, there will be release of free radicals, sir. Because of Fenton reaction, there will be release of hydroxyl free radicals, sir. These free radicals interact with the membrane lipids, sir, and cause the formation of oxidized LDL, sir. So oxidized LDL further causes foam cells production and atherosclerosis, increased atherosclerosis, sir. So this will be the mechanism, sir. So increased ferritin will be a risk factor for stroke, sir.
So you mean increased ferritin is there locally first at the ischemic area and then in the serum also it is increasing, released into serum.
Sir?
Is it so?
I didn't get you, sir.
It is low because of the tissue damage. It is released locally. Then it has become entered into the serum and produced high serum ferritin.
No,
So probably
sir.
this should have happened everywhere in any tissue necrosis. This should have happened. Is it not?
No, sir.
Anyway, what are your observations ultimately? What are your
Those
observations
who are having high
in
serum
relation to
ferritin levels,
ferritin?
they had those who are having high serum levels, so greater than usually 300 nanograms per ml, they are associated with bad prognosis, sir, at 4 week follow-up. They have usually severe to moderate disability.
So if you said so many antioxidants are released in a stroke, can we use clinically any antioxidants are useful?
Yes, sir, we can use iron chelators and we can also use antioxidants. For vitamin C or vitamin E are also shown to have a good effect, sir, in stroke patients.
So you advocate to reduce ferritin in stroke
Yes,
as an
sir.
antioxidant.
Yes.
Okay. Is it clinically useful? Any antioxidants? Are we routinely using any antioxidant?
No, sir.
So likewise, several theories have come over the last 50 years regarding various antioxidants that are released after ischemic stroke and antioxidants, but none of them are clinically useful.
Yes, sir.
They are only, we say they are released, they produce, they aggravate the local damage, but clinically, no antioxidant is really clinically useful recovery. It doesn't lead to. Anyway, thank you. Thank you.
Thank you.
Next Sirisha. Next Sirisha.
Next Deepak. Next Deepak.
Please unmute. Please unmute Sirisha.
Good morning, sir.
Ah,
Sir, am I audible?
what is your
sir?
study? What is your
My
study, Sirisha?
Sir, my study is correlation of ESR CRP with volumes of hyperintense areas on the MRI, sir, and their impact of that markers on the stroke severity outcomes, sir.
Correlation of ESR and CRP as
Yes, sir.
the initial presentation with early brain damage and their influence on in-hospital outcome.
Yes,
So
sir.
what are your observations?
So ESR and CRP are elevated in those patients with the worse outcomes, sir. And then those who are having higher rise in the ESR and CRP, they are having bigger lesions on the MRI, sir. When we calculated the MRI areas or the MRI areas, they are having the higher brain lesions, sir.
So what do you think? Is the ESR and CRP causative, or is it effect or the cause? Cause for a large infarct, or because of large infarct they are rising?
So because of the large infarct, they are rising, sir.
So they are in any other infarcts also they are increased, ESR and CRP. What are they called as?
So they are acute phase reactants.
Reactants. So they are increased in MI, acute pancreatitis, sepsis,
Yes, yes, sir, yes, sir.
coronavirus disease. In everywhere they are
Sir,
increased. So in
sir,
what way they are specifically related? And
so
regarding
we
recovery, you
excluded
are
actually I excluded all the remaining
okay. You
categories.
excluded all other causes. I understand. But how many minutes you have taken for your presentation? You have taken 11 minutes. What is the
sorry,
time given
sir.
to you? 6
6
minutes.
minutes, sir.
And some of your slides are more than 20 lines. Being a student of Dr. Allad is Mohan Garu, who always professes about how to present. చెప్పారా లేదా ఎప్పుడన్నా సార్ చెప్పింది విన్నారా ఎలా ప్రజెంట్ చేయాలన్నది స్లైడ్స్ ఎలా తయారు చేయాలన్నది ఈజ్ ద బెస్ట్ టీచర్ ఇన్ అవర్ స్టేట్ ఆయన దగ్గర పనిచేస్తే మీరు కరెక్ట్గా యూ మస్ట్ లెర్న్ ఆల్ దీస్ థింగ్స్ నువ్వు ఎక్కడైనా ప్రజెంటేషన్ టైం ఎంత ఇచ్చారో దానికి యూ మస్ట్ రెడ్యూస్ యువర్ presentation. So what is important only you must include. You need not elaborate about HS, ESR, what is ESR, what is CRP. You need not write all those things.
Okay.
Understand? That is also important.
Okay.
సో ఇంకేంటి క్వశ్చన్? అంతే అంతే. నీ స్పెషల్ కామెంట్స్ నేను రాసుకుంది అది 11 నిమిషాలు, ఓవర్ క్రౌడెడ్ స్లైడ్స్ అండ్ ఇది
Sorry.
కాజ్ ఆర్ ఎఫెక్ట్. అందుకని అది బాగా చెయ్యమ్మ. మంచి ఇన్స్టిట్యూట్ లో ఉన్నావు. రీడ్ వెల్ అండ్ డూ వెల్ నెక్స్ట్ టైం. ఓకే, థ్యాంక్ యూ. థ్యాంక్ యూ.
నెక్స్ట్ జస్వంతి.
Hello.
నెక్స్ట్
Hello.
జస్వంతి.
Hello.
జస్వంతి,
Please
హలో
start
డాక్టర్
your video.
జస్వంతి.
Class,
Good morning,
start
sir.
your video.
Please start your video, madam.
Okay, sir.
Good morning, Tanli. What is your study?
Clinical and biochemical profile of ischemic stroke in diabetes mellitus, sir.
What biochemical profile? బయోకెమికల్ ప్రొఫైల్ అంటే ఏం చేసావు? డయాబెటిస్ మెలిటస్, స్ట్రోక్ అన్నావు.
HbA1c and lipid profile చూసాను సార్ బయోకెమికల్ ప్రొఫైల్ లో. అండ్ కెరోటిడ్ డాప్లర్ తో కరెలేట్ చేసుకున్నాం సార్.
ఈ లెవెల్స్. సో క్లినికల్ ప్రొఫైల్ కూడా అన్నావు.
Yeah, sir. Type of stroke and type.
క్లినికల్ గా ఏమున్నాయి? వాట్ ఈజ్ క్లినికల్ ప్రెజెంటేషన్?
Most common presentation is hemiplegia and hemiparesis, sir, followed by hemisensory, sir, followed by hemisensory loss, followed by vertigo. Yes,
followed by
vertigo presentation, sir. PCS stroke presentation. Vertigo, sir.
Vertigo is due to which arterial territory involvement?
PCA territory, sir.
Okay. How does the HbA1c cause carotid atherosclerosis?
HbA1c itself doesn't cause carotid atherosclerosis, sir. It's due to high glucose levels, and which itself causes endothelial damage and it causes dyslipidemia, sir. All over, it causes carotid atherosclerosis, sir.
So, your results? How are your results?
My results were HbA1c correlated with LDL cholesterol and non-LDL cholesterol and triglyceride levels, sir. And it doesn't. It showed some correlation with carotid Doppler findings also, sir. But due to the less sample size, there is some deviation in the study, sir.
So, carotid Doppler, what does it show?
In carotid Doppler, we can see carotid intimal thickness, carotid plaques, and carotid stenosis, sir. We can see in carotid Doppler.
Okay. Is atherosclerosis aggravated in diabetes mellitus?
Hyperglycemia causes causes anaerobic lactate production, increases lactate production, sir, which itself causes endothelial damage, and it attracts the platelet plug formation, lipid deposition, sir. And hyperglycemia also causes increased levels of triglycerides and LDL cholesterol and decreased HDL cholesterol, which itself causes atherosclerosis, sir.
So, which molecule is important in the initiation of atherosclerosis?
LDL cholesterol.
Of these three?
LDL.
So it is the oxidized LDL which initiates
sir.
the process of atherosclerosis. Okay.
Yes, sir.
What are the clinical signs of atherosclerosis? Clinical signs. Clinical.
There is
radial artery and ఏమవుతుంది? Atherosclerosis ఉంటే రేడియల్ ఆర్టరీ ఏమి థిక్నెస్ మెజర్ చేస్తాం అంటే థిక్నెస్. So it becomes thickened, but clinically it becomes palpable. Arterial wall becomes palpable. ఇంకా అదర్ సైన్స్ ఏంటి atherosclerosis కి క్లినికల్ గా? Brachials, locomotor brachials. Okay, in elderly people you can see. And temporals, temporal arteries also, they become very tortuous and prominent. So tortuous temporals, locomotor brachials, palpable thickened radial artery, and arcus. Ilo emuntundi?
Arcus analysis.
Arcus analysis. These are all signs of atherosclerosis. Clinical ga. Adi. Okay. You need not do carotid EMT to say this fellow is having atherosclerosis. That will detect more early. Okay. Right. Thank you. Thank you.
Thank you.
Thank you, son.
Thank you.
Next, Hemacharita. Hi, Venkat.
Yes, sir, I'm on the line. Hello.
Please start video. Start video.
Hello. Hello.
Hello.
Yes, ma'am,
hello.
you audible.
Hello, Dr. Hema.
Good afternoon, sir.
Good afternoon.
Good
What is
afternoon,
your
sir.
study? What is your paper?
The association between the serum uric acid concentration at presentation as an prognostic indicator in acute ischemic stroke, sir.
In what way does it influence the prognosis? So what is
Elevated
the
serum
effect of
uric
uric acid? Uric acid. How does it affect the stroke?
Sir, here it is used as prognostic indicator, sir. In ischemic stroke, there will be infarction of the brain tissue, sir. So uric acid can be produced from it. In other way, whenever there is an ischemia, xanthan dehydrogenase, which is normally present, is converted to the xanthan oxidase, sir. It converts xanthan to uric acid and free radicals will be produced, sir. So if there is more uric acid and free radicals production, free radicals causes more damage, sir. So that's why we can correlate as an prognostic indicator, sir. More free radicals will be produced so that more damage and as a poor prognostic indicator, sir.
So ultimately, is it the cause or effect?
Sir, in some studies there is desiccate.
Is it
In some
a cause or effect?
Sir, here I
What
take
is your
it as
opinion?
an here I am taking it as an outcome, sir. But in other studies, it is taken as it is an antioxidant, so it is used as an risk factor also, sir. In increased
It is
levels,
antioxidant. If you give more uric acid, it should be have beneficial effects. Ante kada?
sir, but if elevated, it's normally it is antioxidant, sir. But if elevated
normal
levels
levels.
are present, it will be insoluble and it will aggravate the risk factors, sir, to provoke stroke, sir.
So how many of your patients had hyperuricemia?
Sir, totally I took 51 patients, sir. Out of which 24 patients are having elevated levels, sir.
Okay, how many of them recovered?
Sir, out of 51 patients, 30 are having good outcomes, sir. 21 having poor outcomes, sir. Out of which 14 are having elevated levels, sir. Out of the 21 patients,
So only
14
as
are
a prognostic indicator. Okay.
here I used as prognostic indicators, sir.
Okay, thank you. Thank you.
Thank you, sir.
Yes, sir.
Next, Udaya Bhaskar. Next. Please unmute. Udaya Bhaskar. Please unmute Udaya Bhaskar. Please unmute Uday.
Hello.
Okay.
ఒకవేళ నీకు ఇట్లా ఫ్రీ ఉంటే ఎల్లు తీసుకొని వచ్చేసి నీకే పని లేదు అని ఇట్లా ఆడ
After Uday, Divya, then Hema, Shririsha.
Sir, good morning, sir.
Good morning, Babu. What is your name?
Uday Bhaskar, sir.
Dr. Uday Bhaskar. What is your study?
My study is correlation between serum triglyceride levels and severity of stroke, sir.
Severity of stroke. So,
Yes,
what
sir.
is the normal serum triglyceride level you have taken?
Normally less than 150 milligrams per deciliter, sir. But I converted it into millimoles per liter, sir. So normal triglyceride level is less than 1.7 millimoles per liter. Sir. So I take it cutoff point as less than 2.3 millimoles per liter, sir.
How many milligrams?
Sir, 2.3 into 0.0192, sir. So I consider it as
Okay. Sir,
yes.
Then what is your observations? How many patients you have seen followed up?
Sir, I followed up to 60 patients, sir. What I
So
concluded.
what are your ultimate results?
Sir, mean serum triglyceride levels are significantly lower in severe stroke patients, sir, when compared to mild to moderate stroke patients, sir.
They are low. Serum
Yes, sir.
triglyceride level is low.
Yes,
Okay.
sir.
In patients with severe stroke, you said.
Yes, sir.
As per the stroke.
Yes, sir.
So how do you correlate it? So normally the normal what we say is higher the serum lipids,
sir.
the
Yes, sir.
greater the possibility of ischemic stroke.
Yes, sir. Yes, sir.
But how do you correlate this finding? This your observation.
Yes,
Okay,
sir.
this is an observation. We also need to follow up in our studies later. But how do you correlate this?
Sir. Sir. Hello.
Hello, how to correlate?
Sir, first we have to check. First, I check the triglyceride level, sir, whether it is higher or not, and we have to rule out the risk factors, sir. Whether the patient may be in diabetic or in pregnancy, or it may cause the triglycerides, pancreatitis, or the patient is an alcoholic.
Okay. That is not the what my question is simple. How do you correlate your low triglyceride level with a severity of stroke? We said they are inversely related.
Yes, sir. Yes, sir.
Lower the triglyceride level,
the more is the
more severe the
severity of the
stroke.
stroke, sir. Yes, sir.
This is only your observation.
Yes, sir. I observed.
Can you correlate it? Okay, right. Okay. We don't deny your observation,
Yes,
but
sir.
how do you correlate this?
Sir, usually, the mechanism.
We say they are high.
Yes, sir.
In diabetes, they are high. In other dyslipidemias, they are
Yes,
high
sir, in
and
pancreatitis,
related to stroke. But yours is a new finding, anyway,
yes,
which we will also try to follow up. Really,
yes, sir. Yes, sir.
Second, what are the sources of triglycerides in the body?
Sir,
which lipoproteins
sir,
are rich in triglycerides?
Sir, VLDL overproduction may leads to the increase in triglyceride levels, sir.
Where is VLDL produced?
Sir, majorly in hepatic liver, sir.
Liver. In the diet, what happens to whatever we eat triglycerides? What will happen to them?
Fatty
they are
acids.
absorbed or not absorbed?
Sir, usually by hydrolysis it is converted into fatty acids and glycerol, sir.
They are broken down.
Yes,
after absorption, they are again reassembled as triglycerides. How
yes,
are
sir.
they carried? As which
by
molecule?
chylomicrons. Sir.
Chylomicrons. So chylomicrons and VLDL, these two are rich sources of triglycerides in the body.
Yes, sir.
But anyway, your study is a very new finding to all of us. We'll try to see how far this is. This can be repeated or replicated in other studies also. Okay.
Yes, okay.
From which college?
Sir, Rangarai Medical College.
Oh, local. Oh, right.
Yes, sir.
Okay. Thank you. Thank you.
Okay, sir. Okay, sir. Thank you, sir.
Okay, thank you.
Okay, sir. Thank you, sir.
Hello. Sir, good morning, sir.
Good morning, Dr. Divya. What is your study?
Sir,
Dr. Divya.
Sir. Hello.
Hello, Dr. Divya. What is your study?
Sir, my study is about the outcome of
okay.
ischemic stroke and hyperglycemic.
See.
Hello.
Hello. Sir, good afternoon.
Hello, Dr. Divya. Hello, good morning. Good afternoon. What is your study?
Sir, my study is about outcome in ischemic stroke patients with hyperglycemia, sir.
With hyperglycemia.
Glycemia. Yes, sir.
How many patients you have studied?
Sir, I've taken 50 patients into my study, sir.
Hyperglycemia at what time? At the time of presentation or follow-up?
At the time of presentation, sir.
So what could be the causes for hyperglycemia at the time of presentation in acute stroke?
Sir, hyperglycemia could be a cause which has been underlying and is detected at the time of presentation in cases of stroke, sir. Usually that has been the case. And loss of OHA, proper compliance to OHAs was also an important cause in causation of ischemic stroke, sir.
What I am asking is, what are all the causes of hyperglycemia at the stroke, on day one of a stroke? One is a known diabetes.
Yes, sir.
Okay. Second is also a diabetic but not known.
Yes, sir.
Is not detected earlier. Okay.
Yes, sir.
Detected only after some event. That is
Yes,
stroke.
sir.
And
Yes,
third
sir.
cause?
Could be any microvascular event, or could be any underlying condition like family history of diabetes or other confounding factors like
Okay. Diabetes గురించి ఆ రెండు చెప్పాము. Non diabetic all treatment. Non diabetic, diabetic but not known. Presented for the first time.
Yes.
మూడో కాజ్ ఏంటి హైపర్గ్లైసీమియాకి? ఎనీ acute event, either in sepsis or stroke or MI, anything. దాన్ని ఏమంటాం హైపర్గ్లైసీమియా?
Stress hyperglycemic condition.
Stress hyperglycemia.
Yes.
So how do you differentiate ఈ మూడింటిని?
Sir, if there is a transient
ఆల్రెడీ
rise,
హిస్టరీ ఇస్తే ఓకే, హిస్టరీ ఇచ్చిన వాళ్ళని వదిలే, మిగతా ఇద్దరిని. ఈజ్ ఏ డయాబెటిక్ విచ్ ఈజ్ నాట్ డిటెక్టెడ్ ఆర్ ఈజ్ ఇట్ స్ట్రెస్ హైపర్గ్లైసీమియా?
so stress hyperglycemia usually resolves within a certain period of time post treatment, sir. Whereas in cases of frank diabetes, patients require continuous treatment, sir.
అంటే ఓ 2 weeks దాకా తెలియదు అంటావు, స్ట్రెస్ హైపర్గ్లైసీమియానో లేకపోతే డయాబెటీస్ ఆన్ ది స్పాట్. అప్పుడు ఆ రోజే తెలుసుకోవచ్చా డే 1లో? ఇస్ దేర్ ఎనీ అదర్ బయోకెమికల్ పారామీటర్?
HbA1c check chestam.
HbA1c. So HbA1c is high. It indicates that hyperglycemia must be present over the last 3 months. That means he is a diabetic but not detected.
Yes, sir.
Undetected diabetes, that is.
Yes, sir.
Whereas stress hyperglycemia, HbA1c will be normal. Okay.
Yes, sir.
How does hyperglycemia influence stroke outcomes?
Sir,
Mechanism, pathophysiology, and mechanisms.
Sir, usually hyperglycemia has microvascular complications of formation of thrombi, which leads to other conditions like ischemic stroke, sir, which also causes increase in procoagulant substances like protein C and S, which has a high predilection for causation of ischemic stroke, sir.
Okay, that is in a diabetic. Okay. How does a hyperglycemia in a stroke influence outcomes? అంటే ఇప్పుడు నువ్వు వాళ్ళతో ఇప్పుడు బాగా అవుట్కమ్ గుడ్ అవుట్కమ్ ఉందా బ్యాడ్ అవుట్కమ్ ఉందా రిలేటివ్ గా పూర్ అవుట్కమ్ ఉందా హైపర్గ్లైసెమియా ఉన్న వాళ్ళకి
compared to euglycemics, hyperglycemic had poorer outcome in ischemic stroke.
ఎందుకు వచ్చింది అది why is it so? అంటే other mechanisms by which hyperglycemia aggravates or retards recovery from a thrombus or infarct. ఎలా అక్కడ స్ట్రోక్ ఉంది కదా ఇస్కీమియా కాబట్టి ఎనిరోబిక్ గ్లైకోలిసిస్ లాక్టిక్ యాసిడ్ ప్రొడక్షన్ సో లోకల్ గా సో దట్ ప్రివెంట్స్ రిటార్డ్స్ టిష్యూ రికవరీ ఆక్సిడేటివ్ స్ట్రెస్ విన్నాం కదా గ్లూకోటాక్సిటీ హై గ్లూకోజ్ ఈజ్ ఆల్సో టాక్సిక్ సో గ్లూకోటాక్సిటీ లైపోటాక్సిటీ అంటే లైపిడ్ పెరాక్సిడేషన్ oxidant formation and lactic acid formation, anaerobic glycolysis. All these will aggravate or prevent or retard the recovery from an ischemic stroke and make it worse. Adi mechanism adi.
Yes.
So andukani stroke lo fluids ivvacha, dextrose ivvacha.
Usually if he is in hyperglycemic, we avoid dextrose in stroke patients.
Normoglycemic aithe ivvacha.
అంటే నార్మల్ గా కూడా we only prefer
ఏం ఫ్లూయిడ్స్ ఇస్తావు ఇప్పుడు స్ట్రోక్ పేషెంట్స్ లో
రింగర్స్ లాక్టేట్ గాని నార్మల్ సెలైన్ గాని పెడతాం
NS. So why do you prefer NS and RL over dextrose? Because for the same reason,
oxidative stress,
hyperglycemia. If you infuse dextrose, that is going to do more damage.
Yes, sir.
In a ischemic stroke.
Yes, sir.
Okay. చదువు దాని గురించి బాగా చదువు. Thank you.
Okay, thank you.
Yes, ma'am. Yes, ma'am. Sir. Yes, ma'am. Good morning.
Sirisha.
Good morning, sir.
Please start your video, Amma. Sirisha.
Yes, sir. I have shared my video, sir.
Video.
Yes, sir. I have on my video, sir.
Bandwidth is low. అందుకని కనపట్టాల. సరే ఓకే ఆడిబిలిటీ ఉందా వినపడుతోందా?
Yes, sir. Yes, sir. Yes, sir.
ఏంటి ఇదేంటి స్టడీ ఏంటి? Good.
Echo Doppler in patients with cerebral infarction to identify the source of emboli, sir.
To identify the source of emboli.
Yes, sir. Yes, sir.
Okay. Clinically, when do you suspect embolic stroke? When there is a source of embolus. Okay. What are the common sources of cerebral emboli? What are the sources of
non-rheumatic atrial fibrillation? Non-rheumatic atrial fibrillation, sir. Non-rheumatic atrial fibrillation, sir.
Okay.
Bacterial endocarditis.
Okay.
Mural thrombus.
ఎక్కడ మ్యూరల్ థ్రాంబస్ ఎక్కడ ఫామ్ అవుతుంది అంటే ఏంటి మ్యూరల్ థ్రాంబస్ అంటే ఏంటి
apical wall of left ventricle, sir.
ఎందుకు ఫార్మ్ అవుతుంది వై మామూలు లెఫ్ట్ వెంట్రికల్ లో ఫార్మ్ అవుతుందా ఏ టైప్ ఆఫ్ లెఫ్ట్ వెంట్రికల్ లో ఫార్మ్ అవుతుంది
acute myocardial infarction can lead to
following
mural thrombus,
acute MI or a
yes,
severe LV dysfunction, very severe degree of LV dysfunction. When the
yes,
stroke
sir.
output is ejection fraction is very low, then so much stasis is there even in left ventricle that can lead to mural thrombus.
Yes, sir.
Okay. Inka which valvular heart disease usually predisposes to thrombus formation?
Mitral stenosis, sir.
Any
Mitral
tumors?
stenosis, sir.
Okay.
Atrial
Any tumors?
myxoma, left atrial myxoma, sir.
Okay. ఇక్కడ నుంచి ఇవి కార్డియాక్ ఎనీ వాల్వ్స్ which valves? artificial valves.
Mechanical bioprosthetic valves can also cause this, sir.
Mechanical valves with thrombus formation can also produce thromboembolic manifestation.
Yes, sir.
Arteries, great arteries.
Sir? Hello, sir.
They could be source for a cardiac cerebral embolism, atherosclerotic plaques. Okay.
Yes, sir.
Right. So, what are your findings? What are your findings in your study?
I
Your
have taken
findings.
70 patients, sir. I have taken. In that,
Okay. What are your findings?
50% of occlusion seen in 10 patients, sir. In one patient, more than 70% occlusion is there, sir. On echocardiography, there is one patient having atrial myxoma and atrial fibrillation is seen in 5 patients, sir. The major abnormality is focal valve motion abnormality, sir, seen in 25 patients.
Okay. With or without thrombus formation?
Yes, sir.
Okay. What is the treatment for embolic stroke?
We have to treat the underlying cause by giving oral anticoagulants, sir.
Acute phase లో కూడా oral anticoagulants ఇస్తే ఎంత టైం పడుతుంది అవి యాక్ట్ చేయడానికి? They will take time, 48 to 7.
Yes, sir.
కాబట్టి acute phase లో ఏమి చేయాలి?
During acute phase, we have to thrombolyze if there is thrombosis, sir. But as an embolic stroke, there is no need to thrombolyze, sir.
అవును, మరి ఏమి ఇస్తాం మరి ఇంజెక్టబుల్? Which injectable anticoagulant which acts immediately?
Heparin, sir. Heparin, sir.
అది acute phase లో heparin ఇవ్వాలి. తర్వాత oral
Yes,
anticoagulants follow. Okay, thank you.
Sir.
Thank you.
Thank you, sir.
Abstract number 355. Abhinaya.
Hello.
Just a minute. Wait.
ఎవరు?
Myself,
పేరేంటమ్మా?
Abhinaya, sir.
అభినయ.
Yes, sir. Good afternoon, sir. Yes, sir.
Good afternoon. What is your study?
A study of recovery pattern of aphasia and stroke patients, sir.
What is aphasia?
Loss of speech, sir. fluency, competition, repetition, reading, naming and writing.
లాస్ట్ స్పీచ్ అంటే నేను మాట్లాడకుండా కూర్చున్నావు అనుకో, నేను క్వశ్చన్ అని అడిగా అనుకో, నువ్వు మాట్లాడలేదు అనుకో, అదే ఫేస్ అంటాం. నువ్వు రాసావు, నువ్వు రాసింది కూడా మరి నువ్వు చదవట్లేదు సరిగ్గా. నువ్వు రాసావు కదా చూడు, ఎఫ్ఏజియా డెఫినేషన్ ఏం రాసావు చూడు, నీ దగ్గర ఉందా ప్రెజెంటేషన్ ఎదురుకుండా?
ఉంది సార్.
ఏంటి ఏం రాసావు? ఇంట్రొడక్షన్ లో రాసావు చూడు.
Disorder of previously normal language abilities due to damage.
Is a disturbance of language function.
Yes, sir.
అది ఉందా లేదా? ఫస్ట్ ఆ సెంటెన్స్ ఉందా?
Yes, sir.
Aphasia is a disturbance of language function which is already acquired. ఆల్రెడీ మనకు వచ్చింది చేయలేకపోవటం అనమాట. అది దట్ ఈస్ వాట్ ఈస్ aphasia, వాట్ ఈస్ dysarthria? అందుకని
Aphasia is language disability, sir.
సగం తెచ్చిపెట్టింది. dysarthria అంటే
is weakness or paralysis of muscles of tongue, face, lips, sir.
డెఫినేషన్ చెప్పాలి తల్లి. Dysarthria is a peripheral disturbance of speech, pronunciation.
Okay, sir.
Phonation and pronunciation. అంటే వర్డ్ ప్రొడ్యూస్ చేయటం కానీ దాన్ని పలకటం కానీ తేడా ఉంటే పెరిఫెరల్ డిస్టర్బెన్స్ డ్యూ టు టంగ్, ప్యాలెట్, vocal cord problems వల్ల ఉంటే దట్ ఈస్ dysarthria. Aphasia is a central disturbance of language function. అసలు ముందు ఆ రెండింటికి తేడా తెలియాలి కదా కరెక్ట్గా. కరెక్ట్ డెఫినేషన్స్ తెలుసుకోవాలి. మనం మీరు సూపర్ స్పెషలిస్ట్లు అవుతారు రేపు, మీరు మళ్ళీ మాకు చెప్తే చెప్పాలి కదా. రైట్. మరి ఎఫేజియాల గురించి ఏంటి చెప్పావా, చదివావా? మోటార్ ఎఫేజియా అంటే ఎక్కడ లేషన్ ఉంటే మోటార్ ఎఫేజియా వస్తుంది?
బ్రోకాస్ ఏరియా సార్.
అంటే ఎక్స్ప్రెసివ్ ఆర్ మోటార్ ఎఫేజియా. ఇంకోటి ఏంటి, సెన్సరీ ఎఫేజియా, రిసెప్టివ్ ఎఫేజియా?
Sensory aphasia means lesion in the Wernicke's area, sir.
Wernicke's area అంటే ఏ లోబ్ అది?
Temporal lobe, sir. Temporal lobe.
Very good. What is conduction? Very good. What is conduction aphasia?
In conduction aphasia, there is lesion in the association fibers, sir. Arcade fibers are lost, so there will be loss of repetition. The connection between Broca's and Wernicke's areas
loss of repetition main.
Yes, sir.
Okay. Right. అలాగే ట్రాన్స్కార్టికల్ అంటే ఏంటి?
Transcortical motor aphasia means the fibers which receives information of Broca's area are from Wernicke's. Transcortical motor and transcortical sensory areas around Broca's and Wernicke's area.
వాటి కింద మరి ఒరిజినల్ బ్రోకాస్ కి తేడా ఏముంటుంది?
In transcortical there is maintenance of repetition, sir. In Broca's and Wernicke's there is loss of repetition. Yes, sir. In transcortical motor and sensory repetition is intact, sir.
Okay. ఇంకేంటనో నీదేంటనో అసలు నీ
recovery patterns, sir. Yes, sir.
ఏమి ఇచ్చావు రికవరీ కోసం ఏమి ఇచ్చే వాళ్ళకి? ఎనీ స్పెషల్ డ్రగ్?
Speech therapy and anti-inflammatory. Yes, sir. Rehabilitation.
Only they said that of course it is not in textbooks, but even in textbooks they say piracetam has been claimed to improve, in fact, aphasic functions.
Okay,
it is more useful in aphasic patients.
Okay, sir.
Piracetam అంటే ఏంటి? మన ట్రేడ్ నేమ్ ఏంటి? మనం రోజు యూజ్ చేస్తాం సివిఏ వాళ్ళకి. న్యూట్రోపిల్ అని ఐవి ఇస్తామా ఏమన్నా ఎప్పుడన్నా? ఇవ్వట్లేదా?
ఇస్తున్నాం సార్.
అది దట్ ఈస్ పెరాసిటమ్ ఐవి. దట్ ఈస్ ఇన్ ఫ్యాక్ట్ may improve అంటే as far as pharmacotherapy is concerned. The rest of it is only speech therapy. Okay,
sir.
Okay, read about aphasia and dysarthria. Correct.
Okay,
thank you.
Thank you, sir.
Thank you. 37 మనకున్నది. అభినయ. హలో అభినయ.
Yes, sir.
No, you
26
are
and my
online.
serial number.
ఎవరు?
Hello, sir. I'm Abhinay, sir.
అభినయ అంటే ఏంటది?
సార్ గుడ్
ఏంటమ్మా వాట్ ఈజ్ యువర్ స్టడీ? నువ్వేనా? అయిపోయింది ఇప్పుడు అయిపోయింది కదా.
అయిపోయింది,
ఓకే
sir.
ఓకే అమ్మా అయితే
సార్
నీ పేరేంటి? జానకి రామ్ కార్తిక్.
గుడ్ మార్నింగ్ సార్. ఎస్ సార్ గుడ్ మార్నింగ్.
గుడ్ మార్నింగ్
కార్తిక్ సార్.
ఓకే వాట్ ఈజ్ యువర్ స్టడీ?
My study is on evaluation of plasma D-dimer as initial step in CSVT, sir. Plasma D-dimer as an initial
step diagnosis కన్నావా? అంటే
initial diagnosis of CSVT.
ఎందుకు ఎలా అవుతుంది డయాగ్నోస్టిక్ మార్కర్? ఇప్పుడు కోవిడ్ లో అందరూ D-dimer చేయించుకుంటున్నారు. మన ఏంటి పల్మోనరీ ఎంబోలిజంలో D-dimer అంటారు. మన ఇది డయాగ్నోస్టిక్ ఎలా అవుతుంది? అది ఏమయ్యా D-dimer CVT-లో డయాగ్నోస్టిక్ ఎలా అవుతుంది? అంటే ఆర్టీరియల్ థ్రాంబస్ నుంచి సెపరేట్ చేయటమా?
Actually, patients who are diagnosed with CSVT on MRI and MRV, they are subjected to D-dimer, sir.
ఏమైంది? వాట్ హ్యాపెండ్?
D-dimer has high negative predictive value, sir. That is, it helps to rule out cerebral venous thrombosis, sir.
Cerebral venous sinus thrombosis already diagnosed. D-dimer is high, prognosis is poor. Antena? Okay. What is D-dimer? What is FDP అంటే ఏంటి? Fibrin degradation product FDP. దానికి దీనికి తేడా ఏంటి? రెండు ఒకటేనా?
FDP products, yes sir.
రెండు ఒకటేనా?
No sir.
ఏంటి డిఫరెన్స్? చదువు మరి ఎందుకని?
Okay sir.
చదువు. ఓకే చదువు. You must know the difference between D-dimer and fibrin degradation product. Okay, thank you. Sir, thank you.
Okay sir.
Okay, thank you, Dr. Karthik.
Good morning, sir. Good afternoon, sir.
Good morning. Good morning. What is your name? Naga Shivaji.
Myself, Shivaji, sir.
Acha. What is your study?
A study on neutrophil lymphocyte ratio is a early predictor of stroke patients, sir. Predictor of mortality in stroke patients, sir.
What is your conclusion?
Initial presentation of one or 2 weeks increase in neutrophil lymphocyte ratio is the correlated with more mortality in stroke patients, sir.
What are the other conditions where NLR ratio is altered?
Like COVID patients, sir. COVID and MI patients, sir. Myocardial and like acute coronary syndrome, sir.
Acute sepsis lo ఏమవుతుంది? సెప్సిస్ లో కూడా ఆల్టర్ అవుతుందా లేదా? న్యూట్రోఫిల్స్ పెరుగుతాయి, లింఫోసైట్స్ తగ్గుతాయి అందులో కూడా. సో అది సో మెనీ అదర్ కండిషన్స్ ఇట్ ఈస్ ఆల్టర్డ్. సో ఇన్ వాట్ వే డస్ ఇట్ ఎఫెక్ట్ స్ట్రోక్?
సో
ఊరికే నువ్వు అబ్జర్వేషనల్ స్టడీ చేసావు అంతేనా? అది తేడా NLR రేషియో తేడా ఉన్న వాళ్ళలో ప్రోగ్నోసిస్ ఇస్ పూర్. సో డస్ ఇట్ ఇండికేట్ ఎనీ ఇన్ఫెక్షన్?
No sir.
No, not suggested. Suppose infection anukunte, what other biochemical parameter you do? Sepsis, bacterial sepsis.
Serum
what are biochemical? Procalcitone. So if NLR ratio is altered, procalcitonin కూడా చేస్తే that will rule out infection. Okay, thank you. Charlie, thank you.
Okay, thank you, sir.
Thank you. Next.
Dr. Sai Teja. Abstract number 386, Sai Teja.
Sir, myself. Sir, good afternoon, sir.
Sai Tejana, good afternoon.
Yes, sir. Yes, sir. Sai Teja, sir.
So what is your study?
Sir, my study is study of serum vitamin D levels in the acute ischemic stroke patients, sir.
So what is your conclusion?
My study is observational case control study, sir. In our study, we have found out that acute ischemic stroke patients have in the cases group they have more number of vitamin D deficiency patients, sir. So vitamin D deficiency may be the risk factor for development of acute ischemic stroke, sir.
Is a factor which probably retards improvement. Slows down improvement.
Yes.
So what
Yes,
is
sir.
your in what way vitamin D is? What are the functions of vitamin D at the cellular level? How does it related to stroke?
Sir, it is causing endothelial dysfunction, sir.
Elaga? Vitamin D deficiency na.
Yes, sir. Vitamin D deficiency.
What is VDR? Vitamin D in relation to vitamin D. What is VDR ante enti? Vitamin D receptors. Receptors on the cell surface ఉన్నాయి. ఇక్కడ కూడా ఉన్నాయి. సెరెబ్రల్ టిష్యూలో కూడా VDRs ఉంటాయా? చదువు మరి చదివి చెప్పు మరి ఎలా ప్రోగ్రెస్ ఎఫెక్ట్ అవుతుందో అనుకో. సో నీ అబ్జర్వేషన్ ఏంటి? వైటమిన్ డి తక్కువ ఉంటే ప్రోగ్నోసిస్ పూర్గా ఉంది, రికవరీ పూర్గా ఉందని, సివియారిటీ ఎక్కువ ఉంది.
It's a risk factor for acute ischemic stroke, sir. Vitamin D is one of the risk factors, sir.
It's also a risk factor, causative factor అంటావు.
Yes, sir. Yes, sir.
సో విటమిన్ డి ఇంప్రూవ్ చేస్తే స్ట్రోక్స్ రావు అని అంటావు. స్ట్రోక్స్ రావు, క్యాన్సర్ రాదు, ఎంఐ రాదు, డయాబెటీస్.
The prevalence, sir. Decrease the prevalence. Yes, sir.
That is your okay. చూడు వైటమిన్ డి రిసెప్టార్స్ ఎక్కడెక్కడ ఉంటాయో చూడు. వాట్ ఆర్ ది ఫంక్షన్స్ ఆఫ్ వైటమిన్ డి అదంతా చదువు. ఓకే.
Yes, sir.
ఓకే, థ్యాంక్ యూ.
Thank you.
థ్యాంక్ యూ.
Thank you.
ఓకే, నెక్స్ట్.
Good afternoon. Yes, good afternoon, sir.
Good afternoon, Dr. Sai Teja. 18 study. What is your study?
Sir, my study is about clinical presentations of neuromyelitis optica.
What is your name? What is your name?
Rohini Priya, sir. Rohini Priya.
Rohini Priya. Acha. So what is your study? Clinical presentation of NMO spectrum.
Spectrum disorders.
So what are the clinical presentations? What are the
The
clinical
most common
features of
clinical
this?
presentation in our study is the area posthuma symptoms, sir. That is like nausea, vomiting, and interactable hiccups, sir. Followed by patient's presentation at the time of presentation to the hospital is with hemiplegia, sir. But initial presentation is with area posthuma optic neuritis, sir.
So if area posthuma is involved, what symptoms will occur?
In area posthuma involvement, symptoms like interactable hiccups, nausea, and vomiting will occur, sir.
Intractable vomitings and hiccups. Okay.
Yes, sir.
What is NMO spectrum disorders? What is the difference
if
between
patient
NMO,
present
neuromyelitis optica, and spectrum disorders?
In spectrum disorders, there is only partial presentation, sir. There may be only optic neuritis or transverse myelitis, sir. In NMO, there may be both, sir. Optic neuritis plus transverse.
Okay, why optic neuritis occurs very frequently in these NMOs? Why optic
Because
nerve is involved?
acropolis for Alpha-4 is mostly present in that area, so involvement is common in optic nerve and spinal cord gray matter, sir.
So in neuromyelitis optica, what is the other name for it? Neuromyelitis optica?
David disorders.
Davick's disease. No, okay. Transverse myelitis radiologically, which type of spinal cord involvement suggests NMO?
LETM, sir, longitudinally extensive transverse myelitis involving greater than 3 segments.
Longitudinal extensive 3 or 4 segments involvement is suggestive of NMO disorders. What is the treatment?
Treatment for acute presentation, corticosteroids for 3 to 5 days with 1 gram, sir. Followed by we can keep immunomodulatory agents like mycophenolate, mofetil, azathioprine, rituximab, sir. Other agents like eculizumab, tocilizumab can also be advised, but they are not cost effective, sir, for patients.
Okay. How do you differentiate? My own favorite question is always, how do you differentiate transverse myelitis from Guillain-Barré? Clinically. No investigations. You are at a periphery.
Sir, in Guillain-Barré, bowel and bladder was spared, sir. In neuromyelitis optica, bowel and bladder involvement may be present, sir. And
Will be
sensory
present,
level,
number 1. Sensory. What about sensory?
sensory level of sensory, we can demarcate
What
in
level?
transverse myelitis.
Longitudinal or transverse level?
Transverse levels.
A transverse level of sensory involvement, bladder and bowel involvement will suggest transverse myelitis rather than Guillain-Barré syndrome. Okay. Which electrolyte disturbance will also produce acute paraplegia or quadriplegia?
Hypokalemia, sir.
Hypokalemia.
Hypokalemia.
Okay, thank you. Thank you.
Thank you, sir.
Next. Huh?
Yes. Yes, sir.
Shravya.
Yes, sir.
Dr. Shravya Kotar. Entama study enti needi?
Study of spectrum of cavernous sinus syndrome in a tertiary care center, sir. We have tertiary care center. Basically, this study cavernous sinus is a very small area, sir, with varied etiologies. So clinically and radiologically, to know that, to come to one diagnosis, what all things should we keep in mind? For that, we have done this study, sir.
So clinically, when do you say cavernous sinus thrombosis? When do you suspect?
Sir, if third, fourth, sixth, and V1, V2 division of the trigeminal nerve will be involved in cavernous sinus syndrome, sir. It's not necessary that all the 3 nerves will be involved, but it's like a combination of cranial nerves, sir.
It can also have involvement at any demyelinating disorder lo effect avachchu kada.
Usually, sir, this cranial, along with that, they'll also have local cause, local signs, as in proptosis, redness, and sometimes they can also have bruise, sir.
So, especially these 2 things, along with cranial nerve involvement, it is the proptosis, conjunctival chemosis, and eyelid edema,
yes,
which clinically they just definitely point out cavernous sinus thrombosis. Of
Yes.
course, you can confirm by anyway neuroimaging, definitely. Yes. Any causes you have made out here?
Sir, in this study, sir, we found 45% of the patients had infectious causes, of which 7 patients had mucormycosis and 5 patients had invasive aspergillosis and 3 patients had tuberculosis. And next common cause was tumors, sir. Direct tumors or like pituitary macroadenomas compressing the cavernous sinus, or metastatic tumors were also seen, sir, as in lung carcinoma presenting as
lung with metastasis.
Yes, sir. Okay. Metastasis to cavernous sinus.
Very good. You are from which institute?
DY Patil Medical College, sir. Pune.
In Pune.
Yes, sir.
You are from which place? Andhra Pradesh?
Yes, sir. Andhra Pradesh. Andhra, sir.
Which?
Rajahmundry.
Which place? Rajahmundry nunchi andukane. Okay, well done. Thank you.
Thank you, sir.
Charlema, thank you. Okay, unmute just.
Yes, sir.
Platelet parent
Madhuri, sir.
Good afternoon, Madhuri.
Yes, sir.
Good afternoon. What is your study?
Role of platelet to lymphocyte ratio and its correlation with NIHS score.
In what way platelet and lymphocyte ratio? How is it correlated with stroke? Outcomes of stroke?
Platelet to lymphocyte ratio with we see inflammation and thrombosis activity mainly we detect based on platelet to lymphocyte ratio. In acute ischemic stroke patient, inflammatory mediators will be released. So
what will happen?
There may be thrombosis activation will be there, sir.
Platelet lymphocyte ratio ante normal ga enti? How much is normal? Normal platelet count enta?
Normal platelet count 2 lakhs to 3 lakhs ఉంటుంది సార్.
స్టడీ చేసిందని కరెక్ట్ గా చెప్పాలా ఏదో ఫిగర్ చెప్తే ఎలాగా?
2.5 lakhs to 3.3 lakhs సార్.
చదువు సరిగ్గా అలా చెప్పకూడదు. ప్లేట్లెట్ కౌంట్ ఎంత అంటే కరెక్ట్ చెప్పకపోతే ఎలా? పేషెంట్లే చెప్తున్నారు ఈ కాలంలో. నాకు ఇది నార్మల్ అండి, ఎందుకంటే తగ్గిపోయిందని, డెంగ్యూ ఫీవర్ వచ్చిందని. ఏంటి కంక్లూజన్స్ ఏంటి?
High platelet to lymphocyte ratio positively correlated with NIHS scores, sir. Based on severity.
ఏమైంది? ఎక్కువ సివియారిటీలో ఉన్న వాళ్ళకి ఏమైంది? ప్లేట్లెట్ రేషియో
హై ప్లేట్లెట్ రేషియో ఎక్కువ ఉంది సార్. అంటే అట్ ద టైమ్ ఆఫ్ అడ్మిషన్ బట్టి అట్ ద టైమ్ ఆఫ్ డిశ్చార్జ్ రెండు
అంటే ప్లేట్లెట్స్ ఎక్కువ ఉన్నాయి, లింఫోసైట్స్ తగ్గినాయి, అంతేనా? హై రేషియో అంటే అంటే ప్రాబ్లీ దట్ ఈస్ ఏ ప్రోథ్రాంబోటిక్ స్టేట్ అని. కొన్ని అవర్ లింఫోసైట్స్ కనెక్టెడ్ విత్ స్ట్రోక్, అది నాకు అర్థం కాదు.
యాంటీ ఇన్ఫ్లమేటరీ కదా సార్ లింఫోసైట్స్.
ఇన్ఫ్లమేటరీ, అక్యూట్ ఇన్ఫ్లమేషన్, లింఫోసైట్స్ క్రానిక్ ఇన్ఫ్లమేషన్.
అక్యూట్ ఇన్ఫ్లమేషన్,
లింఫోసైట్స్
క్రానిక్ ఇన్ఫ్లమేషన్.
అక్యూట్ ఇన్ఫ్లమేషన్ క్రానిక్ ఇన్ఫ్లమేషన్ పెరుగుతాయా?
క్రానిక్ ఇన్ఫ్లమేషన్.
అక్యూట్ ఇన్ఫ్లమేషన్ న్యూట్రోఫిల్స్ పెరుగుతాయి కదా. బట్ ఎనీవే న్యూ స్టడీ ఎక్కడ ఉందా? దీనికి ఆల్రెడీ స్టడీ చేశారు కొన్ని?
జర్నల్స్ లో ఉన్నాయి సార్.
తీసుకుని నువ్వు కూడా చేసావు, వెరీ గుడ్.
60 పేషెంట్స్ లో చేసాం సార్.
So we will also try to follow it and see what happens. Okay, thank you.
Thank you.
ప్రశాంత్ అసలు వినపడదు.
Good afternoon, sir. My name is Bobby.
Hello, good afternoon, Bobby. ఏమయ్యా నువ్వు రికార్డింగ్ లో గట్టిగా మాట్లాడాలి. వాట్ ఈజ్ యువర్ స్టడీ? గట్టిగా చెప్పు. వాట్ ఈజ్ యువర్ స్టడీ? లౌడ్.
Evaluation of stroke and its clinical profile in adults, sir. Here, evaluating the risk factors of patients presenting with stroke, sir.
5 to 3
The majority of the risk.
హలో, ఈ ప్రెజెంటేషన్ టైం ఎంత ఇచ్చారు? 6 minutes ఇచ్చారు అసలు, అవునా?
6 minutes ఎక్కువ టైం చెప్తున్నారు కొంతమంది.
అదే అది నీ 11 minutes చెప్పావు, 12 minutes. Okay, what are the causes of cardioembolic stroke? Causes of cardioembolic
Most common
stroke.
causes are in my study rheumatic heart disease and patients presenting atrial fibrillation, sir, bacterial endocarditis, and thrombus from the large vessels, sir, like carotid arteries, embolic
Carotid artery and okay.
large vessels.
Okay, any other causes? Young stroke kada nu chesindi young individuals. Anti thrombin 3 deficiency annavu kada, అది కూడా ఒకటి ఉంది వాళ్ళకి.
And hypercoagulable state.
Hypercoagulable state. So what is the treatment for embolic stroke?
Sir, in embolic stroke we do intravenous anticoagulants, sir. Low molecular weight,
which is low molecular weight intravenous కి ఇస్తామా subcutaneous కి ఇస్తారా యూజువల్ గా? Intravenous కి ఇచ్చేది ఏంటి?
thrombolysis.
Anticoagulant లో which is given intravenously? Heparin, unfractionated heparin is given intravenously. Low molecular weight heparins subcutaneously. Usually they are given subcutaneously. Okay, thank you. But time చూసుకోను ఎప్పుడు presentation అప్పుడు అంత టైం తీసుకోకూడదు. Okay. Right. Okay, thank you. Next.
Thank you.
Sir, good afternoon, sir.
Good afternoon, అమ్మ. పేరేంటి?
Srikavya, sir.
Jana Srikavya. What is your study?
Sir, my study is on occurrence of dyselectrolytemia in patients with first episode of seizures, sir.
What are your findings? ఎంతమంది పేషెంట్?
Sir, we have studied on 45 patients, sir, in which 13 patients had electrolyte abnormalities, sir, and a total of 21 patients had other metabolic abnormalities, sir.
Other metabolic.
Yes, sir. And
what is the most common metabolic abnormality which precipitates seizures?
Sir, hypoglycemia, sir.
Hypoglycemia. So what is the most common electrolyte abnormality that precipitates seizures?
Sir, hyponatremia.
More common.
Hyponatremia. Yes, sir.
What are the types of hyponatremia?
Sir, it is hypovolemic, euvolemic, and hypervolemic hyponatremia, sir.
Okay. How do you treat hyponatremia?
Sir, we'll first classify it as acute and chronic, sir. If the presentation is less than 48 hours, it is considered as acute, sir. And in acute, depending upon the sodium level, if it is less than 120, we will be correcting with 3% sodium chloride, sir. Depending upon we'll be calculating the requirement of sodium, and we'll be seeing.
How do you calculate it? How much broad ga? Gross ga?
Sir, we'll be giving the 3% sodium, not exceeding.
How much?
Not exceeding 4 to 6 milliequivalents per day, sir. In case of an acute, sir,
per day.
We'll be correct. We'll be checking.
Correcting.
And correcting, not
so how
exceeding.
Much you can correct? How much you can correct? For only 3 to 4.
In acute, sir. 4 to 6, sir. In chronic, 8 to 10. Up to.
ఎందుకని acute లో ఎందుకని చేయకూడదు 8 to 10 దాకా?
There is pontine myelinolysis and cerebral edema. There is risk of occurrence of cerebral edema.
That is for too rapid correction beyond 10 milliequivalents, but not up to 10 milliequivalents. So you can correct up to 10 milliequivalents per day, even in acute also.
Okay, sir.
How do you calculate deficit? Hyponatremia? You dyselectrolytemia med chesavu kada, andukani you must be able to tell me.
Yes, sir.
How do you calculate? ఎంతో కొంత ఇచ్చేస్తావా?
No, sir.
3% సోడియం క్లోరైడ్ లో ఎన్ని మిల్లీ ఈక్వలెంట్స్ ఉంటుంది సోడియం?
513 milli 513 milli equivalents millimoles, sir.
513 millimoles per
liter, sir. Per liter.
Liter.
Yes, sir.
So what we give is a 100 ml bottle. అందులో ఎంత ఉంటుంది?
51.3 sir.
Only 51 milli equivalents ఉంటుంది అందులో కదా.
Yes sir, yes sir.
ఓకే, కరెక్ట్ ఫార్ములా కూడా చెప్పు, మళ్ళీ చదువు హౌ టు కరెక్ట్ హైపోనాట్రీమియా చదువు.
Sir, how many moles? Yes. How many moles we are? Okay sir.
ఓకే, చాలు, థ్యాంక్ యూ.
Thank you.
పద్మరాజు, శశికుమార్ రాజు, పద్మరాజు. Abstract number 546. అంత అయిపోయింది ఇందాక. హలో, శశికుమార్ రాజు. పద్మరాజు, శశికుమార్ రాజు. మనం అనేది వినపట్టలేదా? ఇది తీసేది. ఇంకోటి వస్తే ఇది పోతుందా? ఇంకేముంది? వన్ లాస్ట్, నెక్స్ట్ లాస్టేనా? ఎవరు రాలేదు? ఇంటూ పెట్టండి. ఇది కూడా రాలేదా? లాస్ట్ 2 రాలేదా? యాసర్ అబ్దుల్. హలో హలో, త్రివేణి వెంకట చౌదరి. హలో, లింగప్ప.
Hello, sir.
Hello, you are?
Hello.
Lingappa.
Yes, sir. My name is Lingappa, sir.
What?
Yes.
What is your study?
Sir, comparative study.
Of study of? Hello? Lingappa. Hello? Hello?
Hello, sir. Hello.
Lingappa.
Yes, sir. Yes, sir. Sir, comparative study of clinical stroke scores with. Yes, sir.
What are the
comparative study of clinical stroke scores? Siriraj and Allen score with the CT brains and predictability of with accuracy and validity.
What are those scores? Avi radiological scores, Sriraj and Allen, no? Sriraj
No,
and
sir,
Allen
bedside scores,
CT
bedside
scores,
scores.
Avi bedside scores.
Yes, sir. Bedside scores.
నేటితో కంపేర్ చేసావు?
సార్ సిటీ బ్రెయిన్ సిటీ స్కోర్
సిటీ స్కోర్ తో ఇవి కొరిలేట్ అయినాయా లేవా?
డిఫరెన్షియేట్ బిట్వీన్ హెమరేజ్ అండ్ సార్ poorly correlated sir.
Purely correlated between clinically ischemia and hemorrhage to differentiate.
Ischemic and hemorrhagic scores sir to differentiate.
ఈ బెడ్ సైడ్ కిన్ను రేడియోలాజికల్ కి చాలా డిఫరెన్స్ ఉంది. ఓకే, ఉందా లేదా డిఫరెన్స్?
Yes sir. Yes sir.
Side scores in radiological ki. So that's why nowadays CT is mandatory.
Is more preferable than
stroke patients. Because clinical scores will not be correct always. Tarada, can you name some stroke mimics? Stroke mimics antaru. Ante stroke lagane untai presentation కానీ stroke కాదు. ఏమని చెప్తావా? హలో లింగప్ప. హలో డాక్టర్ లింగప్ప. Okay, next.
The internet is not stable, sir. Lingappa. Lingappa, internet is not stable.
Okay. You read about stroke mimics. Okay. Right. Sasikumar Raju, Abdul Ashq.
Yes, sir.
Lingappa
Good
garu inga akkarledu. Okay.
Good morning, sir.
Okay, sir. Thank you,
Good
sir.
morning, sir.
Thank you, sir.
Good morning, sir.
Good morning, Amma. Parent, what is your name, sir? What is your name?
Yasser Abdul Ashq, sir.
Yasser Abdul
Yasser,
Ashq.
sir. Yasser Abdul Ashq, sir.
What is your study? Hello? What is your study?
Sir, my case is a posterior reversible encephalopathy syndrome with thrombocytopenia, sir. Yes, sir. My study was it was a hello, sir.
Chep.
Yes, sir.
37. Your study?
Posterior reversible encephalopathy is a press syndrome with thrombocytopenia, sir. Yes, sir. Thrombocytopenia, sir. A case was presented to us, sir. She had syndrome with unusual presentation in which she showed.
Platform presentation kada? Clinical study kada? Idi.
Yes, sir. Something వచ్చింది, sir.
Your paper kada idi? Paper presentation platform single case.
Sir, the platform lo sir. Sir, sir,
single
actually
case
single
study na?
case, sir, ఇది.
Case study na?
Yes, sir. Yes, sir.
Okay, ఇందులోకి
No, sir,
వచ్చిందా?
case presentation, sir. Yes.
Case presentation
Yes,
and
అలా వచ్చేసింది.
thrombocytopenia with what? Presentation. Thrombocytopenia and so what is the presentation? Okay. అది కేస్ ప్రెజెంటేషన్ మరి ఇందులోకి వచ్చింది ఇంకా ఇది ఒకసారి శశికుమార్ రాజు.
హలో సార్.
హలో.
Yes, sir. Yes.
థ్రాంబోసైటోపెనియా ఇంకోటి ఏంటి ప్రెజెంటేషన్ ఏంటి?
Yes, sir. She was presenting high blood pressure and yes, sir. No, sir. Seizure, sir. Stroke.
Seizure.
Yes, sir.
So what is the cause for seizure here?
Sir, she had a previous history of hysterectomy and blood transfusion, sir. 7 days back, she had hysterectomy and blood transfusion, sir. Because of high blood, because of the post hysterectomy complications and blood transfusion, she had a leakage, sir. That is vasogenic edema, sir, in her frontal occipital lobe, sir. Due to and with uncontrolled hypertension.
What is the outcome?
Yes, sir. She was treated with glycerol, sir, and antiseptic, sir. But there was not. We found it. We did SDP, sir. Then she was in her condition, sir.
Okay. Single case study. Okay, sir. Thank you. Right. Thank you.
Thank you so much, sir.
పక్కన సింగిల్ కేస్ స్టడీ ఇంకెవరున్నారు? పైన సాయి ఫణిశంకర్. హలో సాయి ఫణిశంకర్. ఇంకా ముత్యాల త్రివేణు వెంకట చౌదరి and Padmaraju Sasikumar Raju. Okay, none of them are present. Okay. Hello. ఎవరు వేడుతో చెప్ప
Sir, can I close the meeting? Hello?
సరే అరే ఫోన్ మళ్ళా